to the TNOA customary webinar at the 11 o'clock slot on a Sunday, which has become very, very popular. And after 3 months, the TNOA webinar is back again in full flow, and mainly because of the efforts of Dr. Ravi Shankar, and who's been instrumental in getting all the things together, despite the very, very difficult situation what we are facing in Chennai and all over Tamil Nadu today. And let me tell you that these TNOA webinars have become very popular each and every time, whether it's a debate or a court martial or OPL or whatever it is. We had a minimum of 2,500 to 3,000 hits on the YouTube and the Facebook. So the TNOA webinar is very, very popular, very informative, very educative to all the practicing ophthalmologists and the postgraduates as well. And today we have the Glaucoma Masterclass, and we have actually the masters in this field as far as Tamil Nadu is concerned, the glaucomatologists, and with the chairman, Dr. Ramakrishnan, the vice president of TNOA. Let me start the whole process with the welcome address by none other than our dynamic president of TNOA, Dr. Thangavelu.
Thank you, Mohan.
Yes.
Thank you, Mohan. Good morning, everyone. Welcome to the TNOA Glaucoma Masterclass. We have in our midst eminent authorities, teachers in glaucoma. Welcome, Dr. Ramakrishnan, Dr. Ronnie George, Dr. Murali, still waiting for them, Dr. Satyan, Dr. Chitra, Dr. Nagalakshmi. The ever lively, enthusiastic young ophthalmologists and moderators and organizers, Dr. Mohan and Ravi Shankar. The case presenters, Dr. Tarani, Dr. Hempriya, Dr. Pravina. A special welcome and thanks for participating in this webinar. Sure, this masterclass will help us to detect, save, or at least preserve what is left. Anthony Burgess. He aspired to be a novelist. He thought he had a whole lifetime to write his novels, so kept postponing. Suddenly, in the year 1959, at the prime age of 40, Anthony collapsed and was diagnosed to have tumor, and that would most probably live for another year or so. This came as a rude shock to him and his wife. He was concerned about his wife's financial security, and realizing that he had just a year left with no other choice, he quickly decided and started writing as many novels as possible in the short span of life. By the end of 1962, he had written and published 7 novels, including one of his best novels, Clockwork Orange. Fortunately, he did not have a brain tumor and went on to live a long, productive life till the age of 76 and finally died of cancer. This English writer and composer contributed to more than 250 musical works. He wrote 30 novels and more than 25 works of non-fiction, 2 volumes of autobiography. Like Anthony, we are living in times of uncertainties, fear, commitment, but confidently, I can say the present is ours. Let us focus on fighting the present and building a brighter future. Like what William Shakespeare said, we know what we are, but know not what we may be. Yes, we know we are disciplined, knowledgeable, skilled, talented, especially the younger generation. Basically, financially sustainable, we have the potential to use this rare opportunity to our advantage to stand out from the ordinary. We know not what we may be, but we have the strength, just a little positive mindset, and we'll be able to overcome and can surely come out successfully from this pandemic to live longer like Anthony and be remembered like the writer and composer of our professional composer for our professional excellence with humanitarian concern. Like as Martin Luther King said, only in the darkness can we see the stars. Let each one of us brighten up the sky. Our prime concern must be take care of those who made us what we are today, our colleagues, known and unknown, who are fighting the battle. We need not go searching. All we need to do is join the insurance schemes of associations, AIOS, FBS, IMA, FSS, and so on. You are not only contributing to your loved ones, but also directly contributing to the families of our colleagues. There is no better way to express our humanitarian concern and experience the joy of sharing. Here, Mohan is our outstanding example, and Dr. Rajeshwari And Dr. Rajeshwari Mohan just told me that Rajeshwari has contributed her whole hospital to the pandemic, to the COVID ward. Really, I must congratulate her on this occasion. Those who are already contributing, thanks to them for the insurance. And please check your mails and contribute before the end of this month. Money can be earned and spent, but time can only be spent. Thank you for spending your precious time, precious Sunday morning, listening to me, and for patiently waiting to learn from the masters that there is still hope till the end for those seeing through the tunnel. Thank the organizers, Dr. Mohan, Ravishankar, the TNOA MC members, and all the participants. Stay tuned till the end. Thank you. Take care. Thank you, Mohan. Over to Mohan.
Thank you, President, for the inspiring, as usual, inspiring address. And I always admire your, what do you call, the high school temperament you have. Similar to Dhoni or John Bogg, I would say, because the way you just take care of everything, whether it's a sad scenario or a joyful scenario, you do it so very well, and that is a mark of a true leader, I would say. And let me request our Vice President, Dr. Ramakrishnan, who's going to also chair the session. As you know, Dr. Ramakrishnan is the gold standard of glaucoma, not only in Tamil Nadu, but the entire country, and the director of the Aravind Eye Hospital, Tirunelveli. Sir, over to you, sir.
Thank you, Dr. Mohan. Respected President, Dr. Sangivalu, President-elect Dr. Mohan Rajan, Madhavan, and Professor Loganathan, and my dear faculty members and the dear delegates. Good morning to all. Really, I'm very happy to see you all in this peak of pandemic. All of you know, when compared to last year, this year it was so badly affected, and everything was collapsed in all over the, especially over India. So, in this situation, I'm really happy that Dr. Ravishankar and Mohan have organized this wonderful webinar on glaucoma. So all of you know, all the faculty members, Dr. Roni, Satyan, Murali, and Chitra are all well versed with the glaucoma field, and they are in the field for so many more than 3 decades. And also the other members who are going to present the case reports. The topic they have chosen is really, I'm very happy that they have chosen as basic topics in glaucoma. It's very much useful for the budding ophthalmologists as also general ophthalmologists and also the practicing ophthalmologists. This is very, very important because how to go about a case of glaucoma is especially useful for postgraduates and also the glaucoma suspects and other risk factors and some of the clinical scenario, and all these things are very, very important, especially for the, as I mentioned, for growing the budding ophthalmologists. And I'm really very happy because I don't want to take much time. Like you people, I am also very much interested in listening to the words of our glaucoma stalwarts. And with these few words, I'm very happy, and also congratulate Ravishankar as always. I'm very much, what to say, admire of Ravishankar. Elduna India irukkaru. And the very, really, I'm very happy. Wish you all the best. And thank you. And also, I wish all the speakers and delegates a very safe years to come. Thank you.
Correctா சொன்னீங்க சார். ரவிசங்கர் வந்து எள்ளுனா என்னதான், because I have to just tell him and he will organize everything from A to Z. I don't have to even look at it, and he's a well-oiled machine. And now I'm very fortunate to have Dr. Ravishankar amongst us. And today I think the session is being sponsored by Allergan. We have to thank Allergan as well. Thank you very much, sir. I think the topics, as you rightly said, are very, very practical topics chosen by all the faculty, expert faculty, and we'll have a good discussion also. Dr. Madhavan is I would say, the unsung hero as far as TNOA is concerned, a man of action. But he is one person who does all the work but doesn't expect anything in return. And that is what is, I think, the quality, true quality of Dr. Madhavan. And Madhavan, over to you.
Thank you, sir. Thank you for your kind words, sir. Respected President, Dr. Thangavelu, President-elect, Dr. Mohan Rajan, Vice President, Dr. Ramakrishnan sir, the panelists and speakers of the day, a very good morning to you all. So there has been no letter from COVID, but at least we have Dr. Mohan Rajan and Dr. Ravi Shankar to fall back on. Thanks to them, TNOA academic activities are going on in full steam. Thank you, sirs. Since our last webinar, TNOA activities have been going on in spite of pandemic hurdle. On behalf of TNOA, our President-elect, Dr. Mohan Rajan, along with Dr. Raj Shekhar, Dr. Ravi Shankar, and Dr. Nishant, wished and greeted our Chief Minister, Thiru M.K. Stalin, on assumption of post of Chief Minister of Tamil Nadu. We also thanked our CM for announcing solatium of rupees 25 lakhs for the COVID warriors family. I'm sure this gesture will no doubt give confidence and courage to all the frontline warriors. And congratulations to our President, Dr. Thangavelu sir, for being selected as a member of Organ Donation Committee of National IMA. And instantly, he is also made a member of Advisory Committee on Insurance in State IMA as well. So any insurance issues, I think we can approach our President. Dr. Nirmal Frederick has been appointed as a member of the Editorial Advisory Board of Journal of Indian Medical Association. And he's also made the co-chairman of IMA's Standing Committee for Initiative for Prevention of Diabetic Retinopathy, in which incidentally I am also a member. Our sincere thanks to our President-elect, Dr. Mohan Rajan, for his timely Project Oxygen initiative and support to Omandurar Medical College and Hospital. Thank you, sir, for leading the way in these pandemic times. Thank you, and looking forward to a great TNOA Glaucoma Masterclass. Thank you once again.
Thank you, Secretary, for the wonderful work you're doing, and we really admire you for the what do you call the competence levels you have, and you are also you are having a subject of TNOA subject in your fingertips always, and that is really truly fascinating and remarkable. And Loganathan is there. Dr. Loganathan, our treasurer, who's done tremendous work in this pandemic. I'll tell you, tremendous work. Hats off to you, Loganathan. I want Loganathan to say a few words, and then we'll go on to the main session.
Respected President and President-elect, Honorary Secretary and Vice President, other office bearers and faculties for the today's masterclass on glaucoma, and other members of TNOA, on behalf of Office of the Treasurer, I would like to thank you all for guiding me in this during this pandemic, especially the MR sir, who has helped a lot in retrieving our old GST number with the help from the State President of the GST Council. A special thanks on behalf of TNOA sir, and also Ravi Shankar under the sir Secretary also. So, because of the pandemic, everywhere there is a financial crisis. Our association also suffers little bit, though we'll do our routine work without any difficulties. I hope all our members and office bearers will successfully overcome this pandemic with everyone. If it is safe, I will assure that the TN will go in further height, both financially as well as academically. So I wish everyone to be safe and overcome this pandemic. Thank you one and all. Thank you very much, MR sir, for creating this TNOA academic activities, and backbone of this CME, Dr. Ravi Shankar sir, for arranging this wonderful CME, which is very useful and very neglected part in the many of the teaching program. So thank you one and all for giving me this opportunity.
Thank you, Loganathan, for the nice words. And we go on to I'm a co-moderator, Dr. M. Ravi Shankar, and who has been the main force behind this all these webinars. Dr. Ravi Shankar, please introduce the faculty and also the speakers, and then one by one we can start.
Thank you so much for the wonderful opportunity given to me, Dr. Mohan Rajan sir, and Thank you, President Dr. Thangavelu, for allowing us to do this webinar regularly and sharing this academic activity to the entire fraternity of ophthalmology. Thank you. It's my pleasure to sit here and introduce the faculty members. They actually don't need introduction. They have been wonderful in their own profession. They've been so good in their academic work. They've been so good in the clinical work, what they do. And I'm happy to introduce the chairman of the session, Dr. Ramakrishnan, sir. As Dr. Mohan rightly said, the gold standard of glaucoma in this part of the world. And sir, welcome and thank you for accepting to be the chairman of today's session. And I very well know that you'll take the session in a very good way. Thank you so much, sir, for accepting. My pleasure to welcome Dr. Murli Ariga, who practices so good in his academic career as well as in the clinical way he does. He's a wonderful surgeon, by the way, and he heads the Swami Eye Clinic in Chennai and also is the academic director of MNI hospitals. So thank you for accepting to be the faculty, the panelist, as well as a speaker. Thank you, sir. Dr. Ronnie George, once again, needs no introduction. A very famous figure in this part of the world, published so many papers in the field of glaucoma and senior consultant and glaucomatologist in the Tirupati of ophthalmology, the Shankar Nethralaya, Chennai, India. Thank you, Dr. Ronnie George, for accepting to be the panelist as well as the speaker of the day. Dr. Satyan Pathasarathi, who will be joining us shortly. He is presently talking in the Bombay Ophthalmic Association Conference. That's why he's not yet joined. He'll join us shortly. Dr. Mohan, kindly note, he'll be joining us shortly.
Okay.
Dr. Satyan Pathasarathi, chairman of...
already joined, I thought.
Already there.
He's already
Thank
there.
you, Dr. Satyan Pathasarathi. Once again, a fantastic glaucomatologist and a surgeon, has been very professional and in the Glaucoma Society of India, leading way to much other glaucomatologists in this country. Thank you, Dr. Satyan Pathasarathi, for joining us. And other panelist, Dr. Chitra, head glaucoma department of Regional Institute of Ophthalmology, Chennai. Thank you, madam, for accepting. And she's a wonderful teacher, and she's been busy with the DNB exams. She's one of the sought over DNB examiners in this part of the country and representing RIOGH. Thank you so much, Dr. Chitra, madam, for joining us this morning to be the panelist. And the next speaker is Dr. Nagalakshmi, who's been an associate with Rajanaikar for a long time, doing her DNB over here, and now a senior consultant at Dr. Kamakshi Memorial Hospital, Chennai, and also glaucoma consultant at MNI Hospitals, Chennai. Thank you, Dr. Nagalakshmi, for joining us and presenting today's talk. And we have 3 PGs, postgraduate doctors from popular institutions in Chennai. And I'm very happy that Dr. Mohan and Dr. Thangavelu sir accepted to have the PG case presentation in our session. It's so proud for TNI to help support them in doing this presentation so that they get well versed in the examination. I, at this point, request the panelists to just make them feel free when they are presenting and guide them in such a way they present these cases the same way how do they do today in their examinations also. And we have Dr. Praveena from Sri Ramachandra Medical College University. She would be presenting a case. And Dr. Dharini from Agarwal Eye Hospitals. And Dr. Hema Priya from Regional Institute of Ophthalmology. Thank you, head of these institutions, for allowing them to present. Thanks for giving me the opportunity once again, and humble request to all of you to be safe, be very, very cautious in this pandemic situation. Over to the first speaker, Dr. Ronnie George.
Also the timing is
Timing, it would be 15 minutes for the speaker, followed by a 5-minute discussion. And for the case presentation, it's 5 minutes. I think a few cases may extend up to 7 minutes. That's okay. And over to Dr. Ronnie.
Ronnie.
Thank you, Dr. Ravishankar and Dr. Mohan. Thank you, TNO, for the invitation. So I'll basically be covering what I think is important in the evaluation of a glaucoma patient. So whenever you think about evaluating a glaucoma patient, it's not a single time event. It's something that you do not only at baseline, but during every follow-up visit. And historically, all of us have thought about high IOP being equal to glaucoma, but today we know there's more to it than just that. We know that it's a progressive optic neuropathy. So in addition to IOP, you have disc and RNFL assessment has become mandatory. If you just look at the way that we classify glaucoma, we classify it as primary open angle glaucoma or primary or secondary angle closure glaucoma. So the moment you look at the open or closed, you realize that gonioscopy has also become mandatory when you are assessing every glaucoma patient. In addition, you look at primary and secondary. Now this tells you that in addition to IOP, gonioscopy, and the disc, you also need to look for secondary causes.
Ronnie.
Yes, sir.
Can you be a little louder?
Okay, sir.
Thanks.
So in addition to all these causes, you also need to look for secondary causes in addition to the normal parameters that you assess at every visit. So the aims of evaluation are not just limited to diagnosis, because based on your evaluation, you're going to decide how you're going to initiate therapy and how you're going to follow up. So assessment, we spoke about these three, but in addition, you have to look at the history, you have to look at vision, you have to do a slit lamp evaluation, and you have to assess damage using a visual field. So just look at, I'm just going to give you a few points in history. Remember that most glaucoma is asymptomatic, including angle closure glaucoma. And this is important because if there are symptoms that are etiology related, you need to know about it. A family history of glaucoma is important because it not only tells you risk in other people, but it also tells you, gives you a fair idea of how the disease could progress. If there is a history of glaucoma leading to blindness in this family, this is somebody who needs closer follow-up and more aggressive treatment. If on the other hand, this is a disease which occurred at a very young age, again, in the family, this is something that needs to be followed up more closely. Age, of course, all of us know that in addition to both etiology, it also helps you to maintain your target intraocular pressure, because somebody who's younger is going to have a longer life. And also certain types of glaucoma are commoner at a younger age than at an older age. And medical history is pertinent from 2 points of view. One is from the treatment point of view, some drugs you cannot use, and also from the target intraocular point of view, since you're going to assess life expectancy based on this. So during follow-up, history is actually equally important because non-compliance is a very important factor. In addition, most of our patients are elderly, and we should ask for a change in medical history, because it's quite possible that somebody you've been treating for a long while now has developed a heart block, and suddenly a certain class of medications becomes, contraindicated. A slit lamp evaluation is very important. Sometimes, like in a patient who's presenting to you, conjunctival congestion will give you a hint as to whether it's acute angle closure or whether there's a uveitic glaucoma. The presence of an allergic conjunctivitis will guide you to dig questions about steroid use. The evidence of a previous surgery or laser would also give you a hint as to whether there's a secondary cause behind the whole thing. And of course, at every follow-up visit, a drug-induced hyperemia or allergy is important. It's also important to look for scarring or for a bleb assessment in every glaucoma patient, because potentially every glaucoma patient will require surgery at some time in the future. And you need to make sure that the conjunctiva, at least the superior conjunctiva, is fairly healthy, and you need to record whether there are any abnormalities there. Occasionally, you will find something like this under the conjunctiva, steroid depot, which has been given for uveitic glaucoma, and you know that this is possibly the cause for the glaucoma in this patient, and taking that out with or without medical therapy may be enough. A quick look at the anterior chamber. These are very obvious reasons for the glaucoma in this patient. You have altered blood here. You have an intumescent lens causing sort of lens-induced glaucoma. You have iris bombay here, and then you have angle closure with glaucoma flecken. Sometimes you'll see sphincter tears or transillumination defects or an accent field anomaly, which will give you the diagnosis straight away. But occasionally you'll have to look a little closer. You'll need to look for a Krukenberg spindle. If there's a young patient deep anterior chamber with glaucoma, this is something you need to rule out. You may need to look very carefully to identify subtle rubeosis, because some patients you will be able to see this only under high magnification after a careful slit lamp evaluation. The presence of a corneal edema, don't always attribute it to just high IOP.
This could be of viral in etiology, and you may need to avoid something like dorzolamide or consider antivirals too. The presence of keratic precipitates will again give you would open up the possibilities of a trabeculitis or a steroid response or a secondary angle closure glaucoma in such a situation. So slit lamp evaluation forms a very important part of your evaluation. Coming to the minimum standards for IOP evaluation, the CGIG, the Southeast Asia Glaucoma Interest Group, tells you that ideally you should be doing Goldman appellation tonometry for everybody. If not, what is acceptable is a Perkins or a tonopin. But ideally, for a patient who is on glaucoma treatment or for diagnosis, the GAT is the gold standard. Keep in mind the sources of error, the thickness of the of your Myers, the corneal thickness and its impact on IOP and corneal edema. Don't forget that if you have higher corneal thickness, you will require higher, your IOP readings are going to be erroneously high. Similarly, when you have decreased corneal thickness, you're going to get erroneously low readings. But don't make the mistake of using CCT correction formulae to correct your IOP, because no CCT correction formula is perfect. And this graph basically tells you they've applied 3 different CCT correction formulae to correct the IOP of patients in the OAT study. And you can see that all the 3 graphs show you completely different distributions. So there is no surefire way of correcting for CCT, but keep in mind that the central corneal thickness is thick, normal, or low. And that will give you a guide as to how to compare that to patient's IOP there. Keep in mind also that diurnal variation is more in glaucoma size, and peak IOP is usually in the morning and can vary. In rare cases, you can also you do get IOP peaks at night in most people, and you may need to consider doing a 24-hour diurnal sometimes if you cannot explain a progressing disease. So in IOP, get multiple IOP recordings at baseline, either in the same day or different days. Measure the central corneal thickness to give you an idea of how reliable that IOP is. Coming to gonioscopy, now this is really important. While many of us look at the Von Erich and say, okay, this eye is shallow, this eye is not shallow, it is not a surrogate for gonioscopy because it does not tell you what is actually happening in the angle. And the minimum standards for evaluation of the Southeast Asia Glaucoma Interest Group is that you use a gonioscope that permits indentation, like a Zeiss or a Sussman, because that is what is ideally used in angle closure, since it helps you to indent the angle. And since we have a lot of angle closure in India, this is probably the better tool for you to use. Also keep in mind that it should be done in an undilated position in a dark room with a short slit beam. So you know what in this situation, whether the angle is actually occludable or not. Gonioscopy is not restricted to angle closure. You can see something like angle recession, which will tell you what the etiology of the disease is. You can see pseudoexfoliation of the angle sometimes, which will tell you what's happening. Or like in this 28-year-old male with a history of trauma 2 years back who was being treated for secondary glaucoma, you do the gonioscopy and you see one foreign body sitting there. That's a glass foreign body sitting in the angle for 2 years, setting up a trabeculitis. So gonioscopy will tell you what the etiology of the disease is most often, and it is mandatory because you're classifying your disease based on this. And how often do you need to perform gonioscopy? Definitely at diagnosis, and after that on follow-up at least once a year in every glaucoma patient, and whenever there is a worsening in IOP control that you note. For the optic disc, what are the minimum standards for evaluation? What is recommended and what most of us use is a slit lamp ion microscopy using 60 diopter or 90 diopter lens. What is acceptable is a direct ophthalmoscope in expert hands. Keep in mind that for every optic disc evaluation, you need to look at disc size, you need to look at the neuroretinal rim, the optic cup, the retinal nerve fiber layer, look for disc hemorrhages and peripapillary atrophy. It's very good to document the disc. And if you have access to a disc photography, that is the best thing that you can do. Otherwise, a good disc drawing will also help you, especially if you talk about where the vessels bend. A visual field is again essential to diagnose functional damage, and it is essential to assess progression of disease. Keep in mind that whatever technique you use for visual field assessment, it should be threshold testing. There should be a good database associated with it. You should have good progression software, because glaucoma is a long-term.
Sound coming. Where?
Sir, you can't hear me, sir?
No, I have given you. There is a sound, one sound coming along with your this thing. Not coming for you, guys?
No, it's clear, sir. Mohan, sir. We don't hear any songs from our.
I'm also hearing. I'm also hearing a buzzing sound. I think.
Yeah, buzzing sound. Yeah.
Clear for me. Clear for me, except for the
I think
for me also, sir.
volume.
For me also.
Buzzing sound.
Only அப்படியா உங்களுக்கு இருக்குதோ?
Ronnie, from our side, it is clear.
Clear, it's clear.
Okay, okay, fine. Go ahead, Sorry, Mr. Ronnie.
So whenever you come to visual field testing, remember that you need to use a device with a good threshold testing algorithm, which has a good database and good progression software. Visual field testing is not a one-time event in a glaucoma patient. This progression software of your instrument is more important than the machine itself, because that is what is going to help you take care of your patient in good care. Always look at the visual field and compare that with the sort of damage that you see on the disc. Do the disc changes and the visual field changes correspond? And this is really important, because if they don't correspond, you may be, there's a learning curve, or you may be looking at something else altogether. So here you're seeing bipolar rim changes, and you're also seeing a biaquate defect. And here you're seeing a very subtle early nasal step, which corresponds to that small damage that you're seeing in this location. So when it comes to getting visual fields, get a good baseline. Make sure that the visual field defect is repeatable, because a repeatable visual field defect is what is going to confirm the damage. And look for a learning curve. If the visual field defects are getting better at each visit, you know that the damage may not be as severe as you anticipated at baseline. Look at the retina, because there are obvious causes like a CRV or PDR, which can show up on the visual field. Or look for macular pathology, because both it impacts your implications for treatment, as well as it can show up as visual field defects. And I'll share with you this patient, which is a family history of glaucoma, diagnosed elsewhere to be a glaucoma suspect. Appalachian tonometry showed IOPs of 20 millimeters of mercury. The disc looked reasonably healthy, but when you take a closer look at the retina, you can see signs of an old vessel occlusion there. And sometimes an old vessel occlusion can give rise to this sort of a visual field defect. And we basically elected to follow up and did nothing for this patient. So this patient was a glaucoma suspect. A retinal evaluation is what gave us a clue, and we could avoid putting the patient on unnecessary treatment. So when you evaluate a patient, it's important that you classify as primary or secondary, and that requires a good comprehensive glaucoma slit lamp evaluation and retinal evaluation. Classify it as open and closed. Optic disc examination and gonioscopy are essential for diagnosis. And in summary, every glaucoma patient needs a complete ocular evaluation, because only then you'll be able to do justice to them. Thank you.
As usual, really a fantastic presentation, Ronnie. You covered everything, and mainly the basic things and how to go about assessing or evaluating a glaucoma patient, and when you will suspect glaucoma. I think it's going to be useful not only for the ophthalmologist, practicing ophthalmology, but also for the residents. Sir, Dr. R.K. sir, I think it's all yours, sir. Now.
Yeah, thank you, Dr. Ronnie, sir. Really, you have covered everything in a short period of time, both the investigation, the baseline, as well as the follow-up, which is very, very important, and also a little bit of the history, what are the history you have to elicit. And two things you emphasized in the last, that is, one is you should not diagnose glaucoma without a good optic nerve head examination, and second thing is the gonioscopy. Both are important, so very to diagnose glaucoma and also to find out what type of glaucoma. Really, it's very nice. And I hope we have a very good panel in the, so. The IOP evaluation, you mentioned this appellation as well as Tnoa pen, especially Perkins and Goldman. And what about this time of pandemic, which is what about the role of eye care, and another common thing where most of the common general ophthalmologists, they have NCT. What is your thought about that?
So actually, now that we know that the fomite transmission risk is not that high,
okay,
using an appellation tonometer with appropriate sterilization with sodium hypochlorite is actually fairly safe. And we have gone back to doing appellation tonometry on all our patients. As long as you follow the precautions, that's fine. And I think the other important thing is that when you maybe doing an NCT or an eye care is okay if you're screening a large number of patients. But once you have a glaucoma patient, decisions on treatment and change in therapy should be with a Goldman appellation tonometry, because we all know how much variability there is with every tonometer. If you're not going to even standardize our tonometer, we're going to have trouble managing that patient in the long term.
Okay, good.
I just wanted to ask a question as an extension of Dr. RK's question, because in pandemic you don't want to go close to the patient. So what we do is we do a NCT, and then if the NCT shows little light, then we do the applanation. So as a regular screening method, we don't do the applanation now, mainly because in the applanation, I think you go very close to the patient. So what's your opinion? I want the opinion of the panelists, other panelists also, Dr. Chitra Madam and
Yeah.
Sir, we are actually doing NCT and eye care, sir. And if it is a glaucoma patient on treatment, we do applanation tonometry. We sterilize that prism head with isopropyl alcohol and we are using it, sir.
Can you stop sharing the screen?
No, I'm not sharing, sir.
Somebody's sharing the screen.
I think Satyan.
Yeah.
Screen. Yes, yeah.
Yeah. Okay. Any other comments from other panelists, sir? RK sir, I'd like you to.
Ronnie, you not mentioned much about the imaging. Yes, purposely avoided her.
No, sir. I mean, I had 15 minutes, so I said that.
Yeah, just I know that, but yeah.
If you're going to do any imaging.
No, it's a must. Is it compulsory?
I'll put it on. The minimum imaging that you need to do is a disc drawing. If you have access to a fundus photograph, definitely do a fundus photography. And if you have access to OCT, it's a good thing to do. I mean, it gives you additional information. But it should not be at the expense of a visual field or a disc.
Yeah. But anyway, it's not going to change the management protocol, no?
Yes, sir. And technology keeps changing. So this will be the same 20 years down the line, while your OCT would have gone through 3 generations and you will not be able to compare backwards.
Sir, I have one query.
Yeah.
Sir, why did you purposefully we need to avoid the dorsolamin in case of corneal edema or or something?
No. That one patient had a viral keratitis. Viral endothelitis essentially, which was why we were getting localized corneal edema there. And because dorzolamide can have an impact on endothelial damage, it's better to avoid in that particular situation, not for anybody with corneal edema.
Overall, it's a lovely talk, Ronnie. I think you have discussed everything. Any other questions or comments from the panelists?
I think there has been
yeah,
I think the follow-up of patients is now becoming difficult because many patients are not able to come for follow-up.
Yeah.
So I think we have started relaxing the sort of strictness with which we used to do perimetry and follow-up. And we're probably delaying things a little bit and say if a patient we're calling at 3 months, we say 4 months. 4 months, we say 6 months. And we're delaying perimetry also a little bit because patients are simply not able to come. That is one. The second is the choice of medication. Some of the medications which we have prescribed are simply not available in their area and they're not able to come. So I think we have to give a choice of an alternative medication or an alternative drug itself. And also maybe do a teleconsult to get the patient's confidence, and suppose patients are not able to come at all, at least go see the nearest ophthalmologist and at least have a basic vision and IOP checked and so on. So that precaution we're taking. Otherwise, people simply don't come at all. They simply don't turn up, and we have lost many patients who don't simply come for follow-up.
I just wanted to ask, yes, Murli, that's a very important point. Ask all the panelists as well as the chairman here, how frequently you do the fields? Because if you tell the patients, especially older patients, you ask them to do the fields, they say, please leave me alone. I don't want to do the fields. I'll do it next time. Okay. How frequently you will do the fields for a glaucoma?
It depends on the stage of the disease. Suppose early glaucoma or glaucoma suspect, sometimes once in a year, even once in 2 years, we used to do. And suppose early moderate glaucoma, about 8 months interval, 8 to 12 months. In fairly, it's advanced glaucoma, 6 months. And severely advanced glaucoma, we used to do about once in 4 months. But it's most of the time, it's very, very difficult for the patient to compel the fields because we are not going to change the treatment protocol or the medication. No? So usually 6 months, advanced glaucoma once in 6 months, and early glaucoma once in a year. That's what we used to do.
So can we do the treatment based on the OCT, sir? In such cases, when patient not able
OCT, you have to look for the progression.
progression analysis.
And also OCT alone will not help. You have to look at the disc carefully. For that, you should have a periodical serial photograph of the optic disc and also visual fields. OCT alone will not, we won't change the treatment protocol.
Okay.
I won't.
I think the message is very clear. You need to do the fields and also probably assess the disc and clinically, and then take the IOP and do all these parameters. So the problem in the pandemic is, as Murli Eriga rightly said, is the accessibility of the patient now, and they're not able to come. That's why many of the patients are coming with advanced glaucoma, even macular degeneration. They're coming with very severe subretinal hemorrhage and all that, because they're not able to come for the regular monthly dose of anti-VEGFs. So I think we'll go on to the second talk, Dr. Ravi Shankar.
Yes, sir. It is my pleasure to introduce Dr. Satyan once again. From his home, he's now gone into the.
Yes.
Just changed his background now. Over to you for the second talk.
Thank you, Ravi Shankar. First of all, I would like to thank TNOA for this wonderful opportunity. Today's topic is on IOP Plus. Though RK sir has taught us when we joined, he said only there are two medications, timolol and pilocarpine. Either you give this or that, then you send the patient off. But then once we started digging in more and more, the glaucoma seems to be much more deeper. So that was the time where we have just only two medications, and more than that, you have IV mannitol and Diamox. But then now we have enough of medications in the glaucoma. So it is much more deeper than what we thought. And we know very well that India contributes 1/5 of the global burden of glaucoma. And there is some amount of disparity versus the urban versus the rural, being 3.5% and 1.7% in primary open angle glaucoma in the age group of 40 plus. The majority, we know that the treatment pattern is the medications, though we have other lasers and surgical, but that's going to be very minimal in numbers. But the medications takes the most of the things. So there are some principles in the management of glaucoma, especially in the medical management. There are certain key points as well. Just looking at the key points, once if you can detect the relevant structural change, that will really help us to reduce the visual field progression at the follow-ups. That is the key points. And looking at the key point 2 is prevention of glaucoma progression starts right at the time of diagnosis. This we know it very clearly. We know that IOP is one of the main risk factors in the development and as well as the progression of glaucoma, but IOP is just not the only risk factor. There are many more risk factors. Just we'll have one illustration here. This is a patient aged 51 with a deviation of 12 in the right and 7 decibel loss in the left eye, the CCT of 540 in eyes. The risk factor in the discourage. There's no exfoliation. And you can see the OCT, the mean RNFL shows 60 micron right and 69 in the left eye. Just looking at the life, one of the other risks we have. Life expectancy in India is about 66.8 years in comparison to the world, but 51 obviously we know that. Any patient we do calculate it for around 80 or 90 years. That's how we calculate. So the remaining there is a 30 years for this
Voice is
particular
breaking.
patient. So how do we really? Is it breaking now, sir?
க்ளோஸா வச்சுக்கிடுங்க.
Voice is breaking.
Is it breaking now, sir?
கொஞ்சம்
okay.
Is it okay, sir?
Yeah, better.
Okay, sir. There's one more person browsing next to me, so that's the problem.
That's the reason.
Okay. So the life expectancy is in the middle, somewhere in the middle, and you have the initial damage we need to assess. How much is the functional damage? That is, we have seen that the mean deviation is about 12 plus. So obviously it is in the advanced stage. Then we have the status of the other eye. We have to look at the other eye also. It is kind of early, or we can say go for a non-early. And we have the additional risk factors of a disc hemorrhage in this patient. And the initial level of damage, always we look at which eye has more damage, that is the eye which we really take it. So that's an advanced damage. So when you really calculate the risk profile for this patient is somewhere between moderate to high, that's what we really look at. That's how we calculate the risk. So once we calculated the risk, then the next thing is looking at the, how do we really set the target pressure for this particular patient. So we haven't even taken consideration of the intraocular pressure. Now you incorporate the target pressure, say the right eye is 26 and 22 in the left. So with this evidence, how do we really go ahead and set the target pressures? We have some rules. In an early glaucoma, if the mean deviation is that is less than 6 decibels, then you can set the IOP of less than 18 millimeters of mercury. Moderate 15, advanced glaucoma 12, and terminal glaucomas you set it below or around 10 millimeters of mercury. This is how we really go in. For sometimes we do look at the percentage, but this is the numbers we can on a range we can say, but there is no real single pressure levels for every patient that we need to understand. So looking at the NTG also, we have to go with the early, moderate, and severe with the 15, 12, and 10 millimeters or lesser in NTGs. This is important chart. Just look at this. In ocular hypertension treatment study, we know that reduction of intraocular pressure, even the early manifest glaucoma treatment trial, we know that reduction of intraocular pressure significantly reduces the progression. But in an advanced glaucoma or moderate to advanced glaucoma, though it correlates, but it may not be really completely based on that. What we really need is looking at that 10 or 12 millimeter is the only way to go. There is no way we are looking at the percentage of reduction. We have to go with the 12 or lesser in the advanced glaucomas. That's what it says. So the initial treatment, when you start with the initial treatment, always we go with the systemic contraindications, ocular characters, all these things we'll have to just look at. And most of the time we go with the prostaglandins now than going with the beta blockers. Of course, one can select that, but we have to select the most potent of the drugs looking at your target pressures. But as of now, most of the studies quote that the bimetoprost most likely be the one of the best ocular, IOP reducing agents. So looking at the key point 3, there is a early detection of early visual field progression, which will definitely help us to prevent further visual field loss. Just to look at, I think there was another discussion was going on just a few minutes earlier, how often you do the visual fields. The first 2 years, what we need is at least 6 to 7 visual fields to understand how the progression is happening for these individuals. And also it is important to understand the first 2 years gives us a overall view, how do we really want to treat these patients. So the early manifest glaucoma treatment study has shown that about 14% of the treated patients did show a progression in the first 2 years. And the UK glaucoma treatment study also shown about 15.2% when the IOP reduction was about 20%. So this is the visual field progression. And what are all the points that you will have to look at to say that these patients will most likely will progress faster than the others? Look at the nasal superior and the inferior, and also the paracentral inferior areas. Of course, if you have both the hemifields are involved, then these patients have a highly likely chance to have more progression. The other area is the structural damage. As the newer OCTs that come into the market, we can definitely look at the structural damage and also the progression much better. So looking at the structural progression, do we really have similar to the visual fields? It is still not up to that level, but we can definitely look at least 4 to 6 tests in 2 to 3 years time will give us an idea how these patients are kind of progressing. So once you have bone damage, then you have to consider much lower intraocular pressures. That's what it is. When you have seen the progression in the first 2 years of all these patients, then you have to either add a new drug or go for a much better IOP control. So probably most of the time, if you look at the end of 1 year, majority of the patients, at least say about 50% of the patients may require additional medications to control the intraocular pressure or to achieve the target pressure level. So you can always go for the additional combination of medications. So what is other important factor is, can you identify who are the fast progressors versus slow progressors by looking at the visual fields? So if you have a fast rate of progression, that means about say more than a decibel loss per year, these patients are definitely fast progressors in comparison to those who have, say for example, less than 0.6 decibel loss per year. So these are two examples. This is a slow progressor. You can see that the IOP is 18.4 millimeters. Over a period of 8 years, we don't see much of a progression in this. Though the age group is 57, and you look at this age group, it is not much. It is close to 50 years. But IOP is also similar. But then this patient has 1.5 decibel of loss per year. Then you can see that these patients will progress much faster. Just by looking at the intraocular pressure, it is just not sufficient enough for you to treat your patient. That's why we are saying we got to look at structural changes, functional changes, everything you assess, and then you put the set the target pressures. When you want the maximum medical therapy, you can go for 4 drugs. That's now it is available in 2 bottles. But now you have additional one more drug, that is the rho kinase inhibitors. So 4 plus 1 probably maximum you can go with the maximum medical therapy. So just looking at the intraocular pressure and the glaucoma progression, does every millimeter of mercury really helps to reduce the risk of progression? Yes, this is a very famous thing, that the SAVE site is, which has been developed by Allergan with Anders Hale. So the importance of 1 millimeter of mercury, all the major trials have shown that the risk reduction is about 10 to 15% per millimeters of IOP reduction. So when you this the regularly we saw this chart very often. This is the target intraocular pressure chart. But there are 3 key areas in this. One is how much is the glaucomatous damage, and how much is the life expectancy, and how much is the untreated intraocular pressure levels. So with these 3 factors taken into account, and this is the, let's draw this chart. See the normal rate of progression, those who are above 40 years, all of us do lose amount of the axonal loss will be there. So that is a normal visual decay is about 0.07 decibels per year. But in glaucoma, it is 10 times much higher. The common rate of progression is somewhere around 0.6 decibels per year. This is a treated glaucoma population. But if it is untreated, then you can expect the rate of progression to be 1 or more than 1 decibels, depending upon the intraocular pressure and also other various risk factors. So this is the normal how it is. So when you have a patient and you need diagnosed close to around say 60 years of age group, and this is how the median rate of progression. And if there is a 1 millimeter or 2 millimeter higher diopter, you can see that how much the quality of vision can be compromised with a serious visual field loss. But if you can just reduce that 1 to 2 millimeters of intraocular pressure, that means there is about a 20% slower progression, where you can see that the quality of vision can be maintained throughout his lifetime reasonably. So there is about 7 additional years. there are many medications you can just look at. Now, of course, the most commonly used medication is the prostaglandins, and you have the beta blockers, carbonic anhydrase inhibitors, alpha agonist, and the rho kinase inhibitors. But whatever said and done, if your patient is applying the medications properly, come for a regular checkup, then you might be able to save their eyesight. But the moral of the story in this is that it is just not enough that you just look at the intraocular pressure and treat your patients. You need to just understand how important the visual fields, the OCT, and other various risk factors, and try to understand and set the target pressure to treat all these patients. Thank you so much.
That was a brilliant talk, Satyan, as usual. Really fantastic, and you have opened up actually a new vista and seeing glaucoma independent of the IOP. So, despite the fact that because we have many patients, despite the fact that their pressures are less than 12 or 10, they show progression. So you're not talked about the carotid Doppler. You do them regularly for these patients who have progression.
Yes, sir, but that is not the true indicator unless you have the carotid Doppler shows that flow is completely restricted. Then this may be important in some of the patients. Of course, the sleep apnea, is another important risk factor in the progression of glaucoma, but I didn't include every aspect of it. But what I'm saying is in this is the clinically, how do you really look at the progression other than your intraocular pressure to understand and treat the glaucoma. So obviously the blood flow, ocular perfusion pressure is one of the main risk factors, and the apoptosis in some of the patients, and also the secondary toxic substances like release of nitric oxide. All these things definitely causes damage, but we really cannot assess how much is the damage which is being caused by them.
Over to Dr. R.K. sir for discussion.
Thank you, Satyan. It's a lot of talk. Mainly, you have emphasized on the role of intraocular pressure. Even though there are so many risk factors, the only modifiable risk factor is the intraocular pressure. So you have started with the target intraocular pressure and also various case scenario and also mainly the glaucoma progression. And of course, if you mention some of the other risk factors other than IOP is also very important, like what you mentioned, apart from family history or myopia, or diabetes or hypertension, especially nowadays, this obstructive sleep apnea. One of the commonest problem with most of the people, unless we ask for the history, we will miss this problem. So definitely, it is helping the patient with the treatment with like the CRP and all these things, no. So the history of obstructive sleep apnea is very, very important. And also the other things like, because we already discussed in so many forums, like this hydrotherapy. So many people are at the habit of taking a large quantity of water in the early morning. That's also one of the important thing where it's something like our water drinking test we used to do in the early years, in 90s, 80s, 90s. We used to give 1 liter of water and measure the pressure after half an hour and 1 hour. Anything which is more than 8. But that's also very, very important. Any acute rise in a case with already a glaucoma suspect or glaucoma is also one of the cause for the fastest progress, as you mentioned in your talk. No, that's one of the cause for the fast IOP fluctuation. It will be very high immediately after taking the high quantity of water.
Other is the yoga, sir.
Yes.
Yoga.
Yeah, of course. Yeah, yoga also is especially the Srasasan. Pranayam, I don't think it was have any
Rasasanas.
bad thing. So it's Surasasana is the one thing. Whenever there is increased intracranial, no, that type of thing will definitely hamper the ocular blood flow. That's also we have to ask. And you mentioned about the target pressure. No, Satyan, it's very, very useful for the to set the target pressure, especially the grades of glaucoma, degree of glaucoma, the stages you mentioned. Mainly you mentioned about the how much you have to reduce if the mean deviation is more than 8 or something like that. You mentioned your talk. Can you, for better understanding by the general ophthalmology, can you say visual field this much is the early glaucoma, this much is the moderate glaucoma, or advanced glaucoma?
Okay, sir. I'll just mention, sir, the early glaucoma in the visual fields. I'm talking about the Humphrey visual fields, but you cannot compare this with the octopus visual fields.
Yeah, of course, yeah.
So the Humphreys and octopus, there is about a 4 decibels difference. If it is 12 in Humphreys, it is 8.
You mentioned. No, for general ophthalmology, they cannot go such a deep. No, they will see.
I'll just tell you a little overall easily. If the mean deviation is less than 6 decibels, that is the early visual field damage. That is the early glaucoma, we can say. And the 6 to 12 decibel loss, we can say about the moderate glaucoma. Anything more than 12 decibel loss, then we put it as a advanced glaucoma or severe glaucoma. So these 3 categories, based on these 3 categories only, we try to set the target pressure in majority of the times. And we take the worst eye as the example. Sometimes you have the other eye, better eye, but we really don't consider, but other eye also is equally important. But we look at the worst eye, which has less than 6 decibels, up to 6 to 12 and more than 12 decibel loss. So this is the mean deviation. So based on these, the visual field changes, we go for the target pressure settings. Like when you have a very advanced glaucoma or terminal glaucoma, you look at somewhere around 10 millimeters of mercury. If you have advanced glaucoma, around 12, moderate glaucoma, somewhere around 15, 16, and very early glaucoma, probably around somewhere around less than 18 millimeters of mercury. This is what we look at as baseline target pressures. But having said that, as we are discussing with other various risk factors, the patient still might be progressing. That's what I was telling you. It is just not enough to look at only the IOP levels, but can you really look at the visual fields or the VCT to understand what is going on for these patients? That's why we have to possibly do little early. The first 2 years of visual fields and the VCT gives us a lot of idea to understand how these patients are behaving. So you can really set the target pressures much lower. Some patients may have a lot of fluctuations as well. So these patients probably, once you go for the surgical option, then they may do better. The more than medications, the surgical options, the fluctuations that are the diurnal variability is little lower with the trabeculectomy surgery. So actually, like when we were mentioning about the sleep apnea, I've heard about whether the patient is becoming better or not. That's one thing. On the lighter note, the partners are really happy because they are not snoring. The other partner can sleep better.
That's a good one. I think we should take the panelists' opinion also, Dr. Chitra, Murli. Yeah, quickly.
For we divide the patients. Severe glaucoma, we keep the target pressure as low teens and mid teens for moderate glaucoma, and for mild glaucoma in high teens. We set the target pressure like that. Apart from that, in case of we do Doppler study for patients with normotensive glaucoma, especially these patients, we subject them to routine cardiac and cardiac status and Doppler study and neurological evaluation, and assess the risk factors for them for the progression in normotensive glaucoma.
Murli?
I think I agree with all whatever has been said. Just one more point to add. find that many patients with the so normal tension glaucoma, in addition to and ocular blood flow analysis, also find low blood pressure at night. So I started doing what is called as ambulatory blood pressure monitoring. And ambulatory blood pressure monitoring means a 24-hour monitoring of the blood pressure with the cuff in place, and there's a monitor which is kept. So if you find a nocturnal dipper in the blood pressure, and that can actually, you can discuss with the physician and think of sort of changing the treatment for the blood pressure, avoiding the nocturnal dip in the blood pressure.
So you tell the physician not to give the antihypertensives in the night.
Absolutely. We find some of them have even 90, 40 and 100, 60
Yes.
and very low pressures, and they're over-treated for blood pressure. So that can actually cause problems.
Okay, I think we can go for the next talk, sir.
Yeah.
Yes, sir. Ravi Shankar.
Sir, I just wanted to add one small point actually.
Yes.
By just looking at the age, many times we may not be asking certain questions like, are you doing yoga or other things, water drinking? But let's not look at that, because many of our patients, they do a lot of sirsasana, or this water drinking, they have a regular habit. So it is better as a routine, we ask all the patients all the questions to establish how their nature is, so that we can treat these people better. Thank you.
Absolutely. I think you hit the nail on the head, Satyan. Thanks for the nice, lively presentation. Murli.
Yeah, thank you. And sincere thanks to TNOA and, of course, Dr. Mohan and all our friends in the panel. And my very
Thank you so much, Satyan Pathasarthi.
Yeah, thank you, TNOA, my friends, and the panel, Dr. Mohan and Dr. Ravi Shankar, who has invited me to talk in this very nice TNOA symposium. Am I audible and clear?
Yeah, it can be a little louder, Murli.
Sure. I'm going to talk about the role of lasers in glaucoma, and with a disclaimer that I have no financial interest. And we all know that to the patient as well as to all our treating fellow ophthalmologists, that lasers are a very attractive treatment option, and because they are less invasive than surgery, done as an office procedure, so with a lot of interest in lasers in glaucoma. And the various types of lasers, various delivery systems, and various options for treatment. I think obviously we can't cover all of this in our short talks. I'm going to briefly focus upon only certain procedures which we commonly do, that is iridotomy, trabeculoplasty, and cyclodestruction. The less common ones, I think I have listed here, is more for the postgraduate, and there's a lot of literature available, and you can actually read up. A lot of information is available. Common procedures first, the laser peripheral iridotomy, what, when, and how. The pupillary block is relieved by the laser iridotomy. As you can see, the typical iris Bombay, and you have the iridotomy which relieves it. This is the schematic, and this is the UBM, showing you the change in the configuration of the iris in a typical angle closure relative pupillary block when the PI actually relieves the pupillary block. The indications are absolute indications. PACG is primary angle closure glaucoma, primary angle closure when the IOP sign angle is narrow and you have sine K pigmentation and so on. Pupillary block and pseudophakic eyes. And of course, when you have an acute attack, control the IOP medically, improve the condition, inflammation, corneal edema before you do the YAC. These are all absolute indications for the YAC PI. Prophylactic indications, you would do it for the fellow eye of the acute attack. And also in certain conditions where you have narrow angles in diabetics and you want periodic routine dilatation for the diabetics, you want to see the fundus in shallow ACs, narrow angles. And also IOP elevation, and the IOP has been elevated when the patient has been dilated earlier. Nanophthalmos, and of course the fellow eye of malignant glaucoma. All these are prophylactic indications. And you would prefer the NDAG most of the time because it's a cutting laser, cuts faster, and may have a little bleed, a smaller opening. But you can also consider in very certain situations and rare situations the argon laser also. A coagulating laser which takes more energy and little more painful and can distort the pupil. But you can also consider the argon laser for supplementing the AG laser when you're doing an IAC PI. How do you do it? You're better to pre-treat with pilocarpine, put in a topical anesthetic, and use an Abraham lens, which actually helps to keep the eye open as well as gives you a good magnification, and help choose a crypt in the peripheral iris and sight it generally away from the tear meniscus. And actually it can be done anywhere, but by maybe to avoid the 3 o'clock, 9 o'clock, and the 12 o'clock. Otherwise, I think it doesn't matter where you do. About 300 to 500 micron size of the iridotomy is helpful. and energy depends on the machine. It's generally one pulse per application or a few shots, usually completed in one sitting. Very, very rarely you need a second sitting. Don't overdo it. This is a sequence of pictures showing you the size and the way the iridotomy is done. And the end point is generally the gush of the aqueous and the pigment from the posterior anterior chamber, and you can actually see the deepening of the anterior chamber. Measure the IOP after an hour, pilocarpine for a day or two, topical steroids for some time for patient comfort and inflammation, and definitely measure the, assess the AC depth, do a gonioscopy, and check for PA patency on the review of the patient. Patency is not just transillumination, you must actually ensure you're able to see through it. And sometimes you may falsely think that transillumination is a patent is PA. The PA is patent. You may have difficulties when you have a large arcus like this, thick iris, peripheral eye, very, very shallow chambers. You can pre-treat with an argon laser and do a second sitting. Don't go on hammering the iris with multiple shots of the ag. You'll end up with a lot of pigment dispersion and you end up with a lot of pain and discomfort for the patient. If you're not able to complete in one sitting, defer it for a week or even longer and then do it slowly, because there's no harm in waiting and doing deferred PI. Serious complications are quite uncommon but possible. You can have a hyphema. Some patients very rarely, very, very rarely have even reported total hyphema after YAG PI if they've been on anticoagulants. Corneal burns, blurred vision, mild inflammation, transient IOP rise, dysphotopsia, lens opacities, corneal endothelial damage, and even closure. When you have a uveitis patient, these YAG PA may completely close after some time. Sometimes we consider doing 2 YAG PAs, especially when your patient has uveitis or a secondary glaucoma. So coming to laser trabeculoplasty, this is then done to enhance the aqueous outflow, first described by Weiss and Witter way back in 1979. And then the SLT came into use more than 2 decades ago. And then we now also have the micropulse diode laser trabeculoplasty also available. So indications for SLT, open angle glaucoma, where you can see trabecular meshwork. Primarily, you can do it supplemented when you have additional medical treatment. In addition to medical treatment, you can also do it after trabeculectomy when you find additional IOP lowering is necessary. With pigment glaucomas, pseudoexfoliation, ocular hypertensive when you want to treat, and other glaucomas in pseudophakia and so on, you can consider. Relative absolute indication is that you must be able to do a good gonioscopy and see if you can see the trabecular meshwork well, and then do not mistake a pigmented Schwalbe's line for trabecular meshwork and start treating that. So make sure your gonioscopy is good and you identify structures in the angle. Don't do it when you can't see the angle and trabecular meshwork and the cornea is hazy, you have vitreous in the chamber, you have active uveitis or neovascularization, you have angle recession and trauma causing the glaucoma. All these are relative contraindications. Don't do SLT in these eyes. You can use, the ideal would be to use the selective laser. Most of us use the selective laser now. You can use a specific lens like the rich trabeculoplasty lens or the Latin lens, which is quite popular. We also now have the Vogue rapid SLT lenses available. The ALT was done at the junction of the anterior third and the posterior two-thirds of the trabecular meshwork, and you used to get a bubble formation and then continue with the treatment. This is the ALT, whereas the SLT has got a larger spot size of about 400 microns, a large spot size, and then the thermal damage is much less, and the end point is a mild, very small bubble formation. You can actually scale down and you start seeing bubbles. Bubbles actually means a little over treatment. And with the micropulse diode laser, you can also do what is called as the MLT laser, in which the spot size is slightly smaller, and the post-op inflammation and the endpoints are actually literally you'll see nothing when you do the micropulse trabeculoplasty. Micropulse trabeculoplasty is not freely available. The SLT is much more popular and more available with most practitioners. Unique features: SLT, it is selective, non-thermal, and can be repeated without causing much harm. And the changes in the trabecular meshwork are generally not seen. And in fact, if you do a gonioscopy after a few weeks after the SLT, you'll probably find no change in the angle at all if you've done it well. And post-laser, you will continue the glaucoma medication for some time till the patient comes for a review. I do not use any steroid drops post-operatively for laser trabeculoplasty. And I generally check the pressure after an hour or so, and then maybe a week and a month. The maximum effect of the laser comes in about approximately 4 weeks after treatment. The SLT is not inferior to the older generation ALT in achieving success in treatment, and works similar to medication, probably works like one drug like latanoprost. So it may lower the pressure by about 20 to 25%, or maybe in some patients even a 30% lowering in IOP, but you will not expect it to work and achieve very, very low target pressure. So mind you that it's good for the mild and moderate glaucomas. For advanced glaucomas needing more than one medication, it will not be enough. SLT complications, mild discomfort, mild photophobia, quite common. A raise in IOP can be noted, but very, very few patients can have a sustained rise in the IOP. I think this must be mentioned in your consent forms that a sustained rise in IOP can be a problem in a very few percentage of patients. But whatever you do, make sure the patient comes back for follow-up, because sometimes the patient thinks you've done a laser and they do not come back for follow-up at all. The follow-up has to be insisted upon, that glaucoma treatment does not end with one single sitting of SLT. And it works like one drug, as I already said. And generally, most patients, I do a 360-degree SLT. And some people have considered 90 and 180 SLT and so on, a degree SLT. If you have intense pigmentation in the angle, if you have pseudo exfoliation and so on, I'd probably do 180 degrees, evaluate the response, and then complete the rest of it. So most often we end up doing 360 degrees in most of the patients. So a very nice trial has been published recently, and subsequent a lot of other literature also is available. This is the LIGHT trial, which actually has come from the UK, and mentions that the SLT is probably a good cost-effective alternative to patients with OAG and ocular hypertension. And its applicability in the Indian scenario is, of course, limited, because many patients do not opt for laser treatment and they prefer to apply eye drops. And also the machine availability is not there in many of the glaucoma centers. So SLT is not so popular in India as maybe in UK and other countries. But generally, we offer it to patients, and when patients are accepting the alternative choice or the option of SLT, it can be done. So lastly, coming to the diode cyclophotocoagulation, and intractable glaucomas with uncontrolled IOPs like trauma, neovascularization, aphakia, congenital glaucomas, post-PK glaucomas, post-via surgery, silicon oil removed glaucomas, and so on. Eyes with vision, which is very limited potential for vision and very uncontrolled, painful blind eyes, we have been treating with, say, cryotherapy, and some centers have used ultrasound. And the diode laser is very popularly used for the effectiveness and portability, makes it the best choice for cyclodestruction. And this has been in use for quite some time. And the various methods of cyclodestruction include the pars plana route, the endoscopic route, and the transscleral route. The transscleral route is the most popular, and the machine which has been in use for a very, very long time now is the transscleral cyclophotocoagulation with the G probe. And this has been used with this kind of a tip in which you give a block to the patient and you apply it in spots and go around. Generally, we don't treat more than half the angle. Common parameters were about 2000 milliwatts for about 1 to 2 seconds, and typically increase the power till you hear a pop sound. The pop actually means a UVL micro explosion. You scale down the power after you hear the pop. This is the standard treatment done so far. Complications are quite common. You can get conjunctival burns, iridocyclitis, postoperative pain, hyphema, hemorrhage, hypotonia and choroidals, and so on. And even sympathetic ophthalmia has been reported very rarely after the diode CPC. The new one the new kid on the block in treatment for the last few years has been the micropulse laser cyclophotocoagulation, which uses micropulse technology to denature the target tissue and minimizes the collateral damage. The application, as you can see, is different from the G probe application. G probe application used to be applied in spots, whereas the micropulse is applied in a sweeping movement, avoiding the 3 o'clock and the 9 o'clock. You sweep the sweeping movement. The duty cycle is 31.3% with an on time of 0.5, off time of 1.1, and generally is applied for 80 seconds in 2000 in each quadrant below and above. And this is how it is done. I usually do it in the OT setting with pulse oxy monitoring with an anesthetist standby. And this is the machine and this is the probe. To take all the sterile precautions, I prefer to use a microscope when I do the treatment. And I'm going to show you a few case examples of where I have done this kind of treatment. This is a patient with primary angle closure glaucoma, very advanced primary angle closure glaucoma, not willing for any surgical options. Pressure is very high with multiple medication and very shallow AC. PI is patent and cupping is 0.9. And this is the kind of patient who actually dread to do trabeculectomy, knowing all the complications of trabeculectomy, and worrying about the shallow AC and the cataract formation, aqueous misdirection, hypotonia, and all the related problems. So we suggested to the patient that the laser option is available and could be done. And to my pleasant surprise, we found that the IOP came down considerably almost from day one. Patient is extremely comfortable and was using steroids for about 2 weeks with the cycloplegic also. The patient has done very well with the micropulse treatment and continue to maintain the pressure with just one medication now from the previous 4 medications. This is another patient with multiple medication, open angles, moderate glaucoma, and severe intolerable to any medication, whether it is Brinzagan, whether it is Lumigan, or any kind of a drop. You get intolerable prostaglandin periorbitopathy and pigmentation and unwilling for surgical treatment. This patient also did well with the micropulse transscleral cyclophotocoagulation, has been under medication now with only one drug and tolerates timolol quite well. A third patient I'm showing you here today is the one patient with a relatively one-eyed patient with first had a phaco trap, then had uncontrolled pressure. As you can see, the iridectomy of the phaco trap, then went on and had an AMED valve, and the pressure still remained uncontrolled. Pressure was still high, and glaucoma was apparently progressing. And then this is the patient to whom we have done the micropulse CPC, and the patient finally had a fair control of the IOP and now continues to be on follow-up with medication. A last case I'm going to discuss and show you today is a patient with who underwent Boston K-Pro for chemical injury in childhood and multiple corneal procedures, and then ended up with Boston K-Pro, and slowly you could make out the pressure could not be measured, but you could make out that the patient's optic disc was showing glaucoma cupping and progression. And this patient, we had no other choice, surgical procedure was possible, and this patient also has done well with the micropulse CPC. Few problems with the micropulse CPC include cost and logistics of the probe and having to pull together patients. A mild fibrin reaction is common. The worry could be about one or two lines drop in the vision. Sometimes pupil can remain dilated if it's not placed properly, and very, very rarely you can get hypotonia and choroidals. And generally, we should try to avoid treating thin areas, blood clots, and the recent surgery, recent post-op, we generally try to avoid. A lot of literature available, our own publication has recently been, our Indian experience has been published recently also. And I just show you a short video before I end. I think the video is not playing. I think the video basically will show you that it's an application, a smooth application of the probe rather than a spot application. And how does it work? It generally works by increasing the outflow and a subthreshold damage at the level of the pigmented ciliary epithelium with no visible scarring. And possibly a pilocarpine-like effect is what has been proposed. So the micropulse transscleral cyclophotocoagulation is an effective, safe alternative to the continuous way we used to use in the past. Can be used in eyes with vision potential and not just intractable glaucomas. You can expect about 30-35% or even more IOP lowering, and reduces the need for multiple medication. No serious complications, but one or two lines vision loss in many patients is actually a concern. But definitely we need to have a longer term study in many of these patients to see how effective it is in our practices. And thank you all for your attention.
Thank you, Murli, for the wonderful talk, really. And I think you covered all the aspects of lasers, especially the Cyclo G6. In fact, I have to thank Murli because we are using your laser only. And what we found in Cyclo G6 is that it's quite effective as far as the IOP control is concerned. But the post-operative inflammation and a couple of patients developed severe choroidals. So how do you avoid that? It's because of excess energy or over treatment or something like that?
I think you should stick to that, strictly stick to the protocol which the company and the guidelines have. Many of the users in the West have also mentioned that you stick to the 80 seconds, 2000 energy protocol, avoid 3 o'clock, 9 o'clock. And it should be a smooth kind of a firm pressure movement on the globe. It should not be applied too much of pressure should not be applied. And it should not be too slow, something like we do it for about 12 to 15 seconds one sweep. And it should not be applied with a lot of force, and it should not be repeated. And if you have a thin area, it should not be treated. But those areas of clots, when you have a hyphema, when you have a subconjunctival hemorrhage, that spot should not be treated because the blood actually helps absorb more energy. So all the spots, I have now stopped getting, maybe initially for the first 5 or 6 patients, I probably had choroidals and hypertonies, and they all recovered well. But for the last 1 year, I have not seen any choroidal or hypertonia in any patient.
Very nice. Dr. RK, sir, your comments?
Nice, Murali. You almost brought up important aspect of the lasers, especially the micropulse. I was happy that you treated some of the primary glaucomas also. With POG and angle closure glaucoma with very good result. This is very much, we are also done in some cases, but not as a routine. But how much of the the ciliary body will involve it. So total 360 or 270?
The area of treatment, sir.
Yeah.
So usually I would treat the inferior and the superior.
Leaving
the 3 o'clock and the 9 o'clock.
3
And yeah, by default, I would do superior and inferior 18 to 80 seconds into 2000 each for each hemi quadrant, hemi field. And suppose if I'm repeating, very rarely I've repeated the laser also after about 3 to 6 months when the IOP control is not adequate, secondary glaucomas, I've repeated. When I'm repeating, I would probably do only 180. I wouldn't do 360 again. So I take that precaution. I tell the patient that he may require one more sitting. The only logistic I'm finding difficulty now is the cost. Cost is an issue because of the pandemic and so on. We're finding it difficult to get in more than 3 or 4 patients in one sitting. Otherwise, the cost becomes prohibitive. And doing it for one single patient is actually a problem. We're trying to talk to the company, and I think, as usual, the MNC companies don't cooperate, and so I think we're having difficulty. And they mentioned so many technical reasons for the cost and timing of the. They say we can work only for 90 minutes and so on.
So is it useful in post-inflammatory glaucoma, sir?
No, madam, no. Post-inflammatory, no, definitely no. And you have active uveitis, immediate post-ops. When you already have inflammation in the eye, better to avoid. And you have frank full silicon oil inside the eye, better to avoid. After silicon oil removal, and then despite that, you still have a post, say, emulsified silicon oil kind of glaucomas. Those eyes, it does well.
In neovascular glaucoma, sir?
Neovascular glaucoma, yes, definitely you can do. What I would do, I have sometimes combined this procedure with an anti-VEGF injection. I would do the anti-VEGF followed by the laser immediately, same sitting. Or if possible, do the anti-VEGF first and then follow it up with this. And or discuss with the referring doctor whether a PRP can be done before you do the laser. Where possible, the media is clear, do a good PRP and then do the cyclophotogrametry.
Yes.
So how long you will wait because you told that 4 patients was on 4 medication, no? After laser, they will continue the same 4 medication or you were able to reduce the number of medications?
Yes, so what I do is at least for the first review, the patient continues all the medication which they were using earlier, including the steroid. The first review is generally the first day or second or third day, and maybe at the a week or so. On the second review, I decide to take off the medication. Sometimes I find the IOP goes to single digit when they're using 3-4 medications. So then I step down a little bit and take off the ones which are most offensive in terms of, I take off the brimonidine, I take off the timolol, something. I keep taking it off depending on the patient's comfort and cost. And generally, we would find that at least 2 to 3 medication you can take off in most patients. Okay. But you will not end up with no medication. That is impossible. You will end up with at least 1 or 2.
And also, you told the SLT, ALT, you won't give steroid post to laser.
Yes, sir.
In this micropulse and transcleral diode, will you steroid or not?
Definitely, you need steroids. So for the diode cyclophoto correction, you definitely need a steroid for comfort. For the SLT, I don't give the steroid because, or even NSAID for that matter, because the SLT actually works by inducing a mild inflammation. So you will find that the IOP drop can be sometimes very low or the first or second day after the SLT, which is because of the inflammation. So in that, when you suppress the inflammation, you actually, the IOP effect actually goes away. So we want a mild inflammation after SLT, and so no steroids and no NSAID SLT, but steroid definitely yes after CPC.
Can be done under local anesthesia, topical anesthesia, or does it require block?
No, ma'am. You have to give a block because sometimes some patients have a lot of discomfort and pain, and better to give a very good block and make sure you give time for the block to be effective. And maybe I even add sensor cane for most of the blocks I give. Make sure the patient is comfortable, and I have an anesthetist for all patients because basically you're giving the block. So I think you have to follow all the precautions, and block is necessary. The post-operative pain relief also is very good with the block. Topical you cannot do, man.
Can't do.
Can I just add a few additional points, sir?
Sure, Satyan. I totally forgot. Satyan is
another. I was in the other meeting. There were
Satyan has been using it for longer than I have been using it.
No. Just to. It's a valuable tool in glaucoma practice, so there is no doubt about it. But the only issue is people think this is going to do the magic once you do the laser, then everything is all right, which is not going to be the truth. Basically, see, when you give medication, we have about 60 to 70% maybe responding. Then you add a medication, then you change a medication, something similar to that. And also when you do the trabeculectomy, it is not that every patient is going to work in trabeculectomy. Something similar to that. When you do the diode, it is not that every patient is going to respond to that. And we are doing this diode, especially where you have done a one trap or two traps, or you have done a tubes, you have put the patient on medication, everything. It is completely a destroyed, almost destroyed eyes. So what we can expect is a reasonable amount of IOP drop. That's why we are saying that we have to still continue the medications. But if the IOP drop is less than 10, then probably one by one we can slowly stop, like what Murli was mentioning earlier. I would stop the drug which is most potentially causing the adverse events. That is the first drug I would take it as stopping the drug. But having said that, the best response, what I have seen in our practice, is those with the post-trabeculectomy patients, where you want to plan for a next trabeculectomy. These patients are the best ones who will respond extremely well. You do the trap, failed, before go for the trap, next trap, you do the diode, CPC, cyclo G6 is the best results I have. These patients, even you can stop the medications also. That is the one thing which I thought I should share with you, so that you can look at that as an indication. Of course, as Murli was mentioning, the probe is one of the most irritating things for us because the expenses are much higher. But unfortunately, at this point in time, we don't have any control over it.
Yeah, absolutely. I think I agree with whatever Satyan has said, and just try to add one small point, that people should not go with the impression that the micropulse or cyclophotocoagulation diode, what you mentioned, is not primary treatment. Do not start treatment primarily as first-line treatment, and many people sometimes call and ask me whether can we do it as a attractive laser option for the patient and take away medication. Start for mild glaucomas, start for primary glaucomas. No, I think it needs a careful glaucoma evaluation. You need to consider medication, need to consider the standard forms of treatment before you offer the option of a micropulse.
Yeah, just to complicate that, Murli's talk, when will you do as a primary is, of course, one is when the IOP is where you cannot really do the trabeculectomy directly. That as the kind of primary option, like IOP is 50s and 60s.
Absolutely.
And angle is completely closed.
Yeah.
This is very shallow, intumescent lens, like NVG. These patients I would look at as a sometimes yes,
Absolutely.
primary option, but definitely not like on all type of glaucomas. POAG straight away go for a cyclo G6. Absolutely no way. Thank you.
Yeah. Ronnie, you have any comments to make on cyclo G6 or any other lasers for the matter?
They've used it a little bit. I have no other comments, sir. Both Satyan and Murli have the maximum experience with the lasers in this group, as far as I know.
What is the reason for more inflammation? Because we never used to see with the regular cyclodiode or the cyclocryo also so much of inflammation. But I feel in cyclo G6 we see more inflammation.
I would look at the other way around, sir. The inflammation in cyclo G6 is absolutely nil. Extremely
Absolutely,
less.
sir. I have not seen any inflammation for the last 1.5 years now. So not even a fibrin reaction, not even.
Very true.
I see nothing at all now. But I think this is just the technique and the choosing the correct patient and the eye, maybe preoperative evaluation, and maybe we could probably look at the pre-op evaluation, the indication, as well as the revise the technique of how you do it. I think you can be confident that the
reduce the energy or something.
No. I think there's no need to reduce the. I think probably would revise the protocols with you some other time. That I'm seeing no inflammation at all. In fact, patients are having a white eye, and I even do sometimes the phacoemulsification the second week after this. So I think it's absolutely quiet. So there's no inflammation at all the last 1 year for me.
Maybe the case which you have seen might have had inflammatory glaucoma or something like that, maybe having a congestion, but definitely the cyclo G6 is
not inflammatory glaucoma.
Inflammatory response is extremely low, sir.
Yeah, the patients were on chronic glaucoma on maximum medical treatment, advanced cupping, and not inflammatory glaucoma. But we've seen some. Initially, we saw, but probably after some time, we probably revised the protocols. Or with experience also, no? Initially, it's probably a learning curve.
True.
And Dr. Ravi Shankar will go on to the next talk. We're running short of time. Quickly.
Before that, there's a delegate question, sir, and
Yes,
there's
yes.
a question and a suggestion from Dr. Rajagopal Govindan. Laser is a good at a short term. Probably lens extraction would have been both clinically and economically. That's one question from them. And then next thing he says is from him, anti-VEGF first, then a week later treatment is the ideal option in my. You can see very good response. Comments from the panelists.
Ravi, we don't have much time, Ravi. I think we have to go fast. Yeah, quickly, one or two comments, sir. Satyan or anybody. Murli.
Yeah, I think the role of the lens in angle closure is now well known. I think not all patients would benefit from lens removals. I think we have to be cautious in deciding that the lens removal will help in every patient. That is one. Second is the sequence of treatment we are all learning, by the way, and which first to do, whether to laser first, injection first, or do simultaneously. We are all learning and evolving. In different patients, we do different things for logistic reasons and so on. So I think it's a good idea if you have plenty of time and the patient can come for multiple sittings. You do the injection first, do the laser, and then probably do the micropulse also. I think all are options, and we are actually all learning, by the way. So we don't have a definite answer.
I'll just tell you quickly about the NVG part. Is go for the injection anti-VEGF, wait for the inflammation to reduce and see how much the IOP is also reducing. And then you can go ahead doing the cyclogesis. So for the time restriction, we'll go ahead with the other presentations. And then if we have some time, then we can discuss that a little later. Thank you.
Okay.
Thank you so much, sir. We'll go on to the next speaker, Dr. Nagalakshmi, Senior Consultant at Dr. Kamakshi Memorial Hospital, Chennai, and Glaucoma Consultant at MNI Hospitals. Over to Dr. Nagalakshmi.
A very good afternoon to the esteemed panelists and other participants. At the outset, I would first like to thank TNOA for providing me this wonderful platform. So I'll be talking about a pitfall in glaucoma diagnosis. So we are all aware of what a typically normal disc looks like. However, this is subject to variations, and disc size is one such important variable which has to be taken into account while commenting on glaucoma in such discs. So we use a slit lamp myomicroscopy to assess the disc size, use the correction factor, and then quantify them as small, medium, and large discs. And we are also familiar with 5 R's in ONH evaluation in glaucoma, which was first illustrated by Murray Finger et al. That is the scleral ring changes, then the NRR changes, the RNFL changes, look for the region of peripapillary atrophy, and the region of look for disc hemorrhages. So these are some of the telltale signs of glaucomatous optic neuropathy, again, most of which we are familiar with. So based on the optic disc appearance in primary open angle glaucoma, we classify them as focal glaucomatous optic disc, myopic glaucomatous optic disc, senile sclerotic optic disc, and generalized enlargement of optic disc. So this is the DLS score, which helps us in quantifying glaucoma based on the disc size and rim to disc ratio, which helps in planning the management in these cases. So in an ideal scenario in glaucoma clinic, a patient walks in with a family history of glaucoma, a baseline IOP of more than 21 millimeters of mercury, a bipolar thinning, a corresponding thinning in the OCT, and a biaquate scotoma, and we are ready to start them on anti-glaucoma measures. But we all know that the clinical scenario, we do not see a typically glaucomatous disc change, neither do we see a typically normal disc. So there are a lot of sensitors. The challenge in glaucoma diagnosis is to a large extent the IOP independent nature of the disease, multiple factors while interpreting perimetry like learning curve, fluctuations, reliability criteria, artifacts, and to complicate things further, jargons like red disease, floor effect, and pre-perimetric glaucoma. Diagnosis, however, is in the details, and that is what makes the disease interesting. So one such interesting case was that of a 53-year-old lady who presented to us for a routine eye evaluation. She had a best corrected visual acuity of 6/6, and anterior segment examination was unremarkable. The IOP was 10 millimeters in both the eyes, and the gonioscopy showed open angle. So just when everything seemed perfect, So this is how the disc looked like. So she had a focal NRR loss in the infratemporal quadrant with an adjacent wedge-shaped RNFL defect and a similar picture in the left eye as well. So quickly we ran through the pertinent history, except for a history of abdominal surgery 1 year back. There was not much of positive history. So then we went on to investigate the patient. The pachymetry was a little less than average. DVT was still in the low teens, and the Humphrey visual fields showed a superior arcuate scotoma with a dense paracentral and nasal defect, and a similar picture in the left eye as well. So this was the OCT image of the right eye, which showed some hyperreflective tissues in the floor of the cup, and not very conspicuous in the left eye. So the OCT macula was fairly normal. So this was the 4-quadrant map, which showed a symmetrical RNFL thinning in both the eyes, and a strikingly normal RNFL in all the other quadrants. So we had a 53-year-old with no complaints of visual deterioration despite the dense central defect, a baseline IOP which was in the low teens, and a symmetrical infratemporal loss of NRR. So where we're looking at one of the glaucoma imitators. So the dilemmas in this case was whether it was an optic disc pit or a coloboma. If it was a pit, whether it was a congenital one or an acquired one, whether to treat or to wait. So we did a little bit of literature review. So talking about an isolated optic disc coloboma, disc colobomas and optic disc pits belong to the same group of excavated optic disc anomalies. They involve mutations of PAX6 genes, and it results from the incomplete closure of the embryonic fissure, which is typically, and they present inferiorly and infranasally. An isolated coloboma of the optic nerve can be present unilaterally or bilaterally. The optic nerve cups are often huge in colobomas with a residual glial tissue in them, well demarcated pigmentary changes with or without RNFLD and SRF. And we also see that the drop in the visual field is more when compared to the drop in the visual acuity. And a lot of systemic and ocular associations are possible. So this is one of the case reports which shows a huge cup and an adjoining wedge defect. So the colobomas of the optic disc come under type 4 in Idaman classification of chorioretinal colobomas. So this is a cohort study where chorioretinal colobomas were studied. About 140 of them were included in the study, and it was found that 40% of them had optic disc colobomas alone. Some of the systemic associations were developmental delay, heart anomalies, seizures, and Charles syndrome. And some of the ocular associations were cataract, nystagmus, and strabismus. Glaucoma, however, was present only in 2% of these eyes. So the first classification of optic disc coloboma was by Dr. Lingam Gopal et al. Published in Ophthalmology 1996. So he has classified the disc colobomas as type 1 to 6, 1, 2, and 3, lying outside the choroidal coloboma, 1 being normal, 2 being abnormal but not colobomatous, and 3 being colobomatous. 4, 5, and 6 were present within the area of choroidal coloboma, with optic disc appearing normal in type 4, colobomatous in type 5, and hardly recognizable in type 6. So this is one other study by Dr. Lingam Gopal et al. In 2007, where he has studied about 30 eyes using OCT. And he's also mentioned about the striking similarity between the two conditions. However, OCT of the coloboma showed areas of high reflective tissue, which arises from the floor of the ectatic area, in contrast to the uniform floor that is seen in a glaucomatous cupping. So we are also familiar with the complication of retinal detachment in chorioretinal colobomas. However, in optic disc colobomas, it is more of a serous detachment. And retinal photocoagulation, which is used as prophylaxis in chorioretinal colobomas, are not recommended in optic disc colobomas because of the likely damage to the papillomacular bundle. So this is another case report which shows the presence of serous detachment with optic disc colobomas, and this is again an autofluorescence image clearly demarcating the level of serous detachment. So talking about congenital optic disc pit, it was first described in the late 19th century by Wheat, and histologically these are herniations of dysplastic retinal tissues through defect in the lamina cribrosa, and it is found to be twice as common in women. The prevalence was noted to be about 0.04 in Chennai glaucoma study and 0.02 in the Beijing eye study. So this is another nice article where the swept source OCT was done in 16 eyes with congenital optic disc pits. So the first one shows a small triangular defect. The second and the third shows a deeper defect with also egress of vitreous into the pits. We can also see the directions of the optic nerve fibers are away from the area of the pit. And the lower two images shows a defect in the lamina cribrosa, which is separated from the sclera. And the last image shows a pear-shaped optic pit where the pitting increases beyond the level of the lamina cribrosa. So talking about optic disc maculopathy, it is found in 25 to 75% of these eyes. And the maculopathy is typically bilaminar appearance with retinal schisis and neurosensory detachment communicating with the disc pit. So the source of the fluid in these conditions is thought to be either from the vitreous cavity, CSF, or leaky blood vessels at the base of the optic disc pit. So pars plana vitrectomy is usually suggested for these eyes. So this is yet another case report of coloboma with disc pit. Here we can see beautifully the descent of the dysplastic retina into the optic pit and also a neurosensory detachment which continues into the pit. So the bottom image shows the retinal schisis, which again extends into the pit. And D-scan also helps in confirming the same. So talking about an acquired disc pit, it is usually found in glaucomatous eyes and eyes with pathological myopia. However, the OCT picture is similar to that of a congenital disc pit. It is considered as a risk factor in glaucoma progression. So the Blue Mountain study reported a prevalence of about 0.19% of acquired pits. And it was in contrast to many other studies, they reported the association with high pressure glaucomas. So among the 9 eyes, about 5 of them had intraocular pressure more than 21 millimeters of mercury. And most of the defects were confined to the paracentral and the nasal quadrants. So this is yet another study of primary open angle glaucomas where they were grouped into those with the optic disc pits and those without the optic disc pits. It was found that the mean nerve fiber layer thinning was found to be higher and faster in eyes with the optic disc pits, and also found the progression was more when it was present in the infratemporal quadrant and in the temporal quadrant. And untreated IOP was found to be a risk factor for progression, so also the presence of disc hemorrhages. Briefly talking about morning glory anomaly, it is this probably results from a failure of the posterior sclera and the lamina cribrosa to develop. This leads to herniation of intraocular contents through the defects, causing a conical funnel-shaped excavation of the disc. The disc is filled with a central white connective tissue surrounded by an annulus of pigmentary chorioretinal changes. Macula can be dragged to the nasal edge of the disc, and yellow macular xanthophyll pigment is often visible, which is called as the macular capture. And most of the retinal vessels arise from the peripheral optic disc margin, running radially and abnormally having a straight course. And the central portion is usually hidden because of the presence of the tuft of glial tissue. And it is also difficult to differentiate between a retinal vein and an artery. So this is again more commonly found in females and mostly found to be unilateral. The visual acuity is often less than 6/60, and sometimes leukocoria can be a presenting sign. So among the ocular anomalies, retinal detachment is quite common with the incidence of about 30% in these eyes. Visual prognosis is considered to be poor when they present with a profound visual loss. Treatment of associated cataracts, strabismus, anisometropic amblyopia may result in regaining of some vision. So talking about the significant systemic associations, that would be basal encephalocele, agenesis of corpus callosum and absent chiasm, narrowing of one or more of the branches of the distal internal carotid artery is known as the Moya-Moya disease in these eyes. So hence a neuroimaging with MR angiography preferably should be advised for these patients. So this is again a case report showing the presence of basal encephaloceles in eyes with the morning glory disease as confirmed by the B-scan. So this is another case report of the Moya-Moya disease where we can see the stenosis of the distal part of the internal carotid artery. So some of the differences between a disc coloboma and a morning glory syndrome would be that the coloboma is usually bilateral compared to the morning glory with no general predilection. It's usually familiar and it's associated with other colobomas of the eye, and usually the characteristic appearance of the coloboma and the morning glory itself will help us in differentiating the two with careful examination. And the different systemic associations, that is cardiac and Church syndrome in case of coloboma, whereas basal NK flow seal and internal carotid stenosis in morning glory. So why should we identify disc anomalies? Because it is associated with systemic life-threatening complications. And we can also anticipate other ocular complications like maculopathy or retinal detachment and manage them accordingly. And amblyopia therapy and vision optimization by addressing these treatable causes could still make a difference in these patients. So the take-home message is, as always, there is no substitute to a thorough disc and macular examination. Fundus photo is helpful. OCT, if swept source is feasible, can clinch the diagnosis in most of the cases. B-scan and autofluorescence can complement the OCT, and always look for progression, which is a key marker for glaucoma. Thank you.
Brilliant, Nagalakshmi. I'm very proud of Nagalakshmi because she's my student, DNB from Rajan Eye Care, one of the best DNB students we have ever produced. And subsequently, she did a glaucoma fellowship in Shankar Nethralaya, and she is a shining star in glaucoma. I'm very, very proud of you, Nagalakshmi. A very beautiful presentation.
Thank you for the kind words, sir.
All the optic dysplasias, which are very, very important for us to know. And quickly, we'll have some discussion, Dr. R.K. sir.
Yeah, so thank you, Dr. Nagalakshmi. So mainly you have concentrated on three aspects in glaucoma pitfalls. That's mainly more that glaucoma, optic dispute, and morning glory syndrome. You done elaborate presentation. That's good. But apart from that, some of the, because in the glaucoma, when you talk about the optic, you mentioned about the mainly the optic disc evaluation, no? So
Yes,
mainly the color of the neuroretinal rim, whatever the remaining neuroretinal rim in the optic disc, the color is very, very important. Suppose the paler exceeds the cup, no? That's one thing we have to be very careful, because most of the pituitary tumors we have diagnosed in glaucoma clinic. One thing we should not forget, because any long-standing optic atrophy may mimic glaucomatous optic disc. And also the other meningiomas, even the sphenoidal meningioma we have seen were presented with this type of a picture where the patient was treated for a long time, and the progression of the visual field, but not corresponding to the horizontal meridian, it's vertical meridian, but ultimately it tend to be a sphenoidal meningioma. So that color is very, very important, color of the neuroretinal rim. That's one aspect we should not miss. And also the methyl alcohol poisoning is also not only methyl alcohol poisoning, even a long chronic smokers and also the alcoholics. That also sometimes they mimic glaucoma. That's one thing we have to be very careful. And some of the other pitfalls in see IOP measurement, especially because I don't know, many of the glaucoma, they won't have the facility to measure the central corneal thickness. So the thickness is very high, so they will have a very high intraocular pressure, and also visual field pitfalls, so many things. But otherwise, it's a good presentation. What about the other panel?
We'll go on to the postgraduate presentation, sir, because we don't have time now. Already we are 1 o'clock.
Okay.
Yes, sir, but I think
Right.
Dr. Ravishankar, please call the postgraduates because they've been waiting for quite some time.
Yeah.
Ravi? Okay, the first postgraduate, who is the first one? Dr. Dharini, yeah?
Yes, sir.
Please, yeah, please present.
Yes. Good morning. Sir, is my screen visible, sir?
Yes.
Dr. Dharini from Agarwal.
Yes, sir. Good morning, one and all. Good afternoon, one and all present here. I thank Ravishankar sir and Rajan sir for the opportunity and the TNOA.
Little louder, Dharini.
Yes, sir. Today I'm going to do a case presentation of a 29-year-old male, an IT professional who came to the hospital with complaints of blurring of vision, of a distance vision, and started noticing difficulty in peripheral vision for past 6 months. which was gradual in onset and progressive in nature. He had no other specific complaints, no history of trauma or previous ocular laser or any surgical history, no history of previous spectacle use, no history of recurrent redness, pain, headache, no history of steroid use in the past of any form, no family history of glaucoma, and he does physical exercises regularly once in the morning. So on examination, systemic examination was within normal limits. On torchlight examination, both eyes extraocular movements were full and free, and Hirschberg was orthophoric. And his best corrected visual acuity was 6.6 with minus 0.75 D spherical on both eyes. Lid and adnexa was normal, conjunctiva healthy. I'll start with the right eye, sir. Cornea, there was a linear iris pigment deposits of length 4 millimeters over the endothelium. Anterior chamber depth was deep along the mid periphery with the concave iris configuration. Iris, there was no translumination defect or no heterochromia. On direct and indirect reflex in the right eye, there was a relative apparent pupillary defect with a normal accommodation reflex. On 90 diopter lens, the optic disc size was small with a cup disc ratio of 0.7 with a thinning of superior rim more than inferior rim, with which defects over the superior and inferior quadrants, and pallor was present. On the left eye, the vision was 6.6 with a minus 0.75 D spherical. Lid and adnexa was normal, conjunctiva healthy. Cornea, there was a iris pigment deposits of length 4 millimeters over the endothelium. Its anterior chamber depth shows deep along the mid periphery with concave iris configuration, no translumination defects or no heterochromia. Direct indirect reflex was normal and sluggish actually, and accommodation reflex was normal. Lens was clear. Optic disc size was small with a cup disc ratio of 0.7 with inferior rim thinning more than superior rim thinning, with wedge effects along superior and inferior quadrants, and pallor was present. So Goldman applanation tonometry undilated was done, which showed 40 millimeters of mercury in the right eye and 38 millimeters of mercury in the left eye. And gonioscopy was done, which was open in all 4 quadrants with trabecular meshwork pigmentation of 3+. So during first visit, the patient was not dilated because of high IOP and was started on oral astazolamine and topical dorzolamine eye drops and was asked to review after 2 days. So follow-up visit after 2 days showed applanation tonometry undilated of 15 millimeters of mercury and 17 millimeters of mercury. And post-dilatation, it was 12 millimeters of mercury in both eyes. Indirect ophthalmoscopy examination was done, which shows no peripheral retinal degeneration in the right eye. And left eye, there was an early lattice in superior temporal quadrant. A pachymetry was performed, which showed right eye with 485 microns and left eye 494 microns, which states it's a thin cornea. And color vision was 17 by 17 in both eyes. So the oral astazolamine and topical carbonic anhydrase inhibitor was stopped, and the patient was prescribed prostaglandin analog bimatoprost of 0.03%. So the OCT disc and RNFL was performed. The signal strength is good, which shows 6 by 10 and 5 by 10. And the RNFL thickness was 60 and 61 in both eyes, right and left eye. There was a thinning in the superior and inferior quadrants. And the RNFL T and NIT normative data showed the superior and inferior quadrant thinning. Fields was done in which it was a reliable fields with a less fixation loss, and it showed advanced field changes with a mean deviation of minus 31.32 and visual field index of 12% in right eye. And left eye, it also showed mean deviation of about minus 27.20. It is a reliable field. And the macular program was performed, which shows a right eye macula split, and left eye showed inferior field defect over the macula. So ultrasound biomicroscopy was deferred due to the COVID situation, and this photography was not performed. So my diagnosis will be both eye pigmented glaucoma with advanced glaucomatous optic neuropathy. Sir?
Discussion, please.
So my questions will be, which is better to start with? The patient was started on aqueous suppressant and then was shifted to outflow. So which is better to start with, sir? And what is the role of YAG peripheral iridotomy or myotics at present era, because they are not using now, because myotics induced myopia, and YAG PI, it is done in the UBM confirmed cases only. So what is its role? And can laser trabeculoplasty tried as a first option, and to whom we can undo that? And what is the long-term effects of trabeculoplasty in a pigmentary glaucoma patient? And role of canaloplasty in the treatment of pigmentary glaucoma, sir, because it treats the pathogenesis. So
Start with can we use prostaglandin analog in pigmentary glaucoma?
Sir, it increases the uveoscleral outflow, sir, and they have started it in this case.
So let the panelists
Yes, sir.
discuss each and every, each
Yes,
of
sir.
them. Yeah. Dr. Chitra, ma'am.
Yes, sir. Sir, ideally, this patient has got advanced glaucoma. What I would suggest is better to do an PI for, YAG iridotomy for this patient using a diluted pilocarpine, since these patients are at the risk of retinal detachment, and subsequently control the IOP with the aqueous suppressants, topical aqueous suppressants. Since the patient is having an advanced glaucoma, these patients usually they better respond to the YAG iridotomy and topical medications. So better to manage these patients with these two procedures.
YAG iridotomy definitely has a role in pigmentary glaucoma because the amount of
Rubbing is more in case of
the rubbing of the iris on the lens and the release of pigments is released reduced. Roni, what's your comment on that, Roni?
Just a couple of things. YAG iridotomy, a couple of randomized controlled trials which have looked at its role in pigmentary glaucoma, and they have actually been inconclusive. But the feeling is that if you do a UBM and you can demonstrate iridozonular contact, in those eyes, an iridotomy is helpful. And I would definitely consider doing a UBM and doing the iridotomy if that happens. In terms of medical management, actually,
Otherwise you don't do YAG iridotomy.
if there is no iridozonular contact, you are not going to reduce the posterior bowing. Because what happens is sometimes you get these people later on when they're a little older, at which time there's not that much of contact. And by doing the PI, you're just setting up inflammation and everything else.
Just by looking at the iris contour, posterior concavity, can we, suppose if we don't have a UBM, can we do laser iridotomy? Because we were doing laser iridotomy for a long time.
Yes, sir.
In type of cases.
Yes, sir. We were also doing it for a long time, but once a UBM came in, we found that it was better when we could demonstrate the contact on the UBM.
Yeah. Okay.
I think we should probably discuss something about the guidelines and take-home messages for the average or general ophthalmologist. I think the message should be that YAG-PI is not a routine for pigmentary glaucoma, and only in selected cases you can consider. I think the old Campbell's theory, I think, was about the pigment dispersion when the iris was concave in the periphery and pigment dispersion was there. I think that has been disproved in many papers subsequently, and none of the guidelines for management of pigmentary glaucoma suggest a YAG-PA as the primary procedure. So I think we should consider and leave the decision to do a YAG-PA to a so-called higher center or a referral center where a YAG-PA would probably be useful in certain very small percentage of patients. I think better to manage medically and treat it as a secondary glaucoma, and also because advanced glaucoma is there, I would probably think of an earlier surgery rather than putting on multiple medication and eventually going for surgery anyway.
I would actually consider using a prostaglandin analog in this patient, because what happens with aqueous suppressants is the pigment has to be washed through the trabecular meshwork. When you're reducing aqueous production, there is less aqueous outflow through the meshwork, and therefore the pigment actually doesn't go through the meshwork. So prostaglandin analogs are today considered first-line therapy for pigmentary glaucoma. They don't increase the pigment dispersion. That is a misconception. They're actually very effective in pigmentary glaucoma, and some of the largest IOP drops you will actually see will be with pigmentary glaucoma.
Absolutely. I would straight away start with the prostaglandin, and suppose it had been a milder or a earlier glaucoma, I would consider an SLT at least 180 or something. But I would, in this patient, probably think of surgery at an earlier stage.
What about cyclo G6 in this, Murli?
No, not as a primary treatment. No.
Not as a primary. Okay. So we'll go to the next case, sir.
Okay. We don't have time.
Who's the next presenter?
Ravishankar.
Thank you, Dr. Dharani, for the wonderful presentation.
Thank you, sir.
Who's the next presenter? Dr. Ravi.
Dr. Hemapriya on Axenfeld syndrome.
Hemapriya is from RAOGH, can present, yes.
Yes, sir.
Please.
Good afternoon, one and all. I am Hemapriya, postgraduate at RAOGH. I'll be discussing a case on a 9-year-old female child who came with complaints of whitish discoloration in both the eyes cornea since birth. There is no other complaints for the child. And the patient had no other systemic features, and there is no significant past history. On anterior segment examination, the child had a vision of 6/6 in the right eye and 636 improving to 612 in the left eye. The central corneal thickness measured by ultrasonic pachymetry was 718 microns in the right eye and 697 microns in the left eye. The intraocular pressure measured by Goldman applanation tonometry was 20 millimeters of mercury in the right eye and 18 in the left eye. Since the CCT is in a higher end, the corrected IOP is 13 millimeters of mercury in right eye and 12 in the left eye. Coming to slit lamp examination, the right lid normal, the conjunctiva was clear, the cornea showed posterior embryotoxon, and the anterior chamber was moderate in depth, pupil reacting to light, and there was the iris showed the prominent crypts and altered color pattern with anterior synechiae noted at 1 o'clock position and from 3 to 6 o'clock position. The lens was clear with a persistent pupillary membrane. The left eye also had normal lids with clear conjunctiva with posterior embryotoxon, and the AC was moderate in depth, pupil reacting to light. The iris showed altered color pattern with prominent crypts and anterior synechiae from 6 o'clock to 9 o'clock position. The lens was clear with a persistent pupillary membrane. Gonioscopy by Goldman single mirror gonioscope showed narrow angles in both the eyes. The fundus in both the eyes was normal. As there was no age-matched values for the child, OCT RNFL could not be done. So since there was bilateral posterior embryotoxon, it is axon-filled anomaly with additional altered color pattern in the iris, such as prominent crypts and anterior synechiae. It is a Rieger's anomaly. Since the child had no specific systemic features, came to a diagnosis of Rieger's anomaly. So my management will be best classes for the refractive error, and at present the IP is under control. Hence, we'll observe the child and review periodically for any increase in IOP or any angle structure changes. A few points about the syndrome is axon-filled Rieger syndrome, a complete development of Fish-Lem's canal. So the presence of posterior embryotoxon is axon-filled anomaly with additional iris changes such as polychoria, chorectopia, and atrophic holes is Rieger's anomaly. So these iris changes with systemic features is the Rieger syndrome. So the spectrum of illness such as posterior embryotoxon with the iris defects and systemic features is the axon-filled Rieger syndrome. So it is an autosomal dominant trait, which is usually bilateral, and these children have more than 50% incidence of having glaucoma along with systemic features. So the corneal features being either a 360 degrees or a temporal quadrant posterior embryotoxon. And the anterior chamber is open, but there is tissue strands extending from the peripheral iris to the Schwalbe's line. Hence, the trabecular meshwork is visible, but the scleral spur is obscured. It shows the chorectopia with stretch holes in the quadrant opposite to the chorectopia. And other developmental systemic features will be dental anomalies such as microdontia or hypodontia, and facial anomalies like telecanthus or hypertelorism, pituitary anomalies, especially empty-cella, or sometimes may be associated with heart defects and skeletal defects. So the pathogenesis being developmental arrest of the neural crest cells. So there is an abnormal retention of this endothelial layer over the iris and the anterior chamber. So this causes an alteration in the aqueous outflow. So this retained endothelium, forms an iridocorneal membrane. Contraction of this membrane causes the iris changes, and this developmental arrest also leads to a high insertion of uvea into the posterior trabecular meshwork. So this leads to incomplete maturation of the trabecular meshwork and the Schlemm's canal, which is responsible for the glaucoma. The differential diagnosis of the IC syndrome is usually unilateral with the endothelial changes with no significant family history, predominantly females. And Peters anomaly usually involves a central cornea, whereas accidental regals involves a peripheral cornea. Aniridia is, we have rudiment iris tissue on gonioscopy, no other significant anterior chamber abnormality. May need to find glaucoma management. So we do aqueous suppressants with beta blockers or carbonic anhydrase inhibitors. Alpha agonist could also be tried. Surgical management, we could try goniotomy or trabeculotomy, but the surgery of choice is trabeculectomy. But still, if the IOP is not under control, we can even go for drainage devices and even cycloablative procedures. I would like to thank TNOA and all my professors for giving me this opportunity.
Very nice presentation, Hemapriya. I will go on for the discussion. Dr. RK, sir.
Yeah, it's a good case. It's a simple case. So what's the cause for defective vision in the left eye, doctor? Right eye 66, left eye 36.
So there is so there was persistent pupillary membrane, so there may be
No, that's
centrally was there, so there may be visual.
Excuse me. Is it ambulatory?
It was not that extensive according to the picture, photograph.
Is it an ambulatory eye? Possibility.
What maybe, but what is the retinoscopy? Have you done any retinoscopy?
Yes, sir, we have done, sir, with 1.5 spheres and 1 cylinders at 110 degrees only. It was improving to 612, sir, from 680.
Mm-hmm. Well, so left eye is improved with the glass or pinhole or?
Yes, sir, right eye was already 6.6, left eye with,
with
yes, sir, 618 to 612 with the glasses, sir.
So there is other associated systemic features like dental anomaly or other skeletal anomaly in this case.
Yes, sir, there was no systemic features.
Okay, sir. Any comments from the quick comments from the panelists? We'll go on to the final speaker.
The high central corneal thickness is a little unusual. It's almost 650, 700 in both the eyes. So I think that's something I would like to keep a watch on going forward.
What's the corneal diameter?
So it was actually normal limits only, sir.
We didn't mention it in that. Not mention it.
Didn't mention, but it was within normal limits.
Normal, okay.
As such, we are only monitoring the patient since the IOP is normal. The patient is under a regular follow-up. Other than that, the posterior embryotoxin and altered iris pattern, the child at present is normal. So we are just following up the patient.
Madam, endothelium is okay, no? Because you have a Pachy of 697, if I'm right.
Corneal thickness is there. We are yet to do the specular microscopy, sir.
Oh, yes. Okay. That's fine, ma'am. We'll go on to the final presenter, Dr. Praveena from Ramachandra.
Thank you, sir.
Good afternoon. This is Dr. Praveena from Sri Ramachandra Medical College. I'm here to present a case today. 52-year-old male from Tiruvallur, auto driver by profession, came to the OPD with complaints of diminution of vision in both eyes for 1 year. He was a known case of primary open-angle glaucoma, diagnosed in 2016. His baseline IOP was 38 in the right eye and 32 millimeters of mercury in the left eye. Baseline visual fields done in 2016 showed right eye superior arcuate defects with VFA of 80% and left eye showed advanced field loss with VFA of 27%. Patient was using Combigan eye drops BD and Latanoprost eye drops at night in both the eyes on and off for a year until he stopped all anti-glaucoma medications 2 years ago by himself before he presented to the OPD in 2020. Past history, no history of steroid use, trauma, bronchial asthma, or sleep apnea. He's a known diabetic on treatment for 2 years, not a known case of hypertension, no family history of glaucoma. Ocular examination on presentation on 7th February 2020. On examination of right eye, visual acuity was 612 with pinhole improving to 6.9, cornea clear, anterior chamber normal depth with Van Herrick's grade 3, iris normal texture and pattern, pupil 3 mm round reacting to light, lens clear, IOP at 11 AM measured with Goldman's applanation tonometry was 44 millimeters of mercury, extraocular movements full and free, gonioscopy done with 4-mirror Sussman lens and classified according to modified RP center grading showed open angle up to scleral spur, no evidence of past and uniform TM pigmentation of 2+. Fundus examination with 90D lens. Right eye, media was clear, average size disc with vertical cup disc ratio of 0.8:1, bipolar rim thinning, lamina dot sign was present, bearing of circumlinear vessels present with superior and inferior notching, macular foveal reflex present, pachymetry 555 micrometers. On examination of left eye, visual acuity was 612, improving to 6.9 with pinhole. Anterior segment was normal, anterior chamber was deep. IOP at 11 AM measured with Goldman's applanation tonometry was 42 millimeters of mercury. Gonioscopy showed open angles up to scleral spur. Fundus examination of left eye, media was clear, average size disc with vertical cup disc ratio of 0.95:1, bipolar rim loss and near glaucomatous optic atrophy, macular foveal reflex present, pachymetry 540 micrometers. This is a summary of the documented disc findings as we did not have a stereoscopic disc photo for all the follow-up visits. In 2016, when the patient presented for the first time, right eye vertical cup disc ratio was 0.7:1 with inferior rim thinning and with inferior notching. And in 2020, it further progressed to 0.8:1 with bipolar rim thinning and superior and inferior notching. In 2021, when we saw the patient for the last time, he further worsened with vertical cup disc ratio of 0.9:1 with bipolar rim thinning and superior and inferior notching. And for the left eye, when the patient came for the first time in 2016, this vertical cup disc ratio was 0.9:1 with bipolar rim loss, which further got worsened in 2020, where the vertical cup disc ratio was 0.95:1 with bipolar rim loss and near glaucomatous optic atrophy, which further got worsened in 2021, where we noticed a mild pallor and grade 1 RAPD. Visual fields of the right eye, the baseline field done in 2016, 24-2 CETA standard program, reliability indices were poor with high fixation losses and false negative error of 12%. A superior arcuate defect was noted with mean deviation of -7 and VFA of 80%. When the fields were again repeated in 2020, reliability indices were again poor with high fixation losses and false positive error of 15%. The same pattern was repeatable and new points were involved. And we noted a double arcuate pattern with mean deviation of -14 and VFA of 58%. Though the fields were not reliable, but the same pattern was repeatable and new points were also involved, which correlated with the disc finding, and therefore we suspected progression. Since the points close to the fixation were involved, we have done a 10-2 field where the reliability indices were again poor with high fixation losses and false positive error of 17%. The central points were seem to be normal. However, this cannot be considered in view of poor reliability. Visual fields of the left eye, the baseline field done in 2016, the reliability indices were reasonably good and the field showed advanced field loss with mean deviation of -24 and VFA of 27%. However, the pattern deviation could not be calculated due to severely depressed field. When we repeated the field again in 2020, the reliability indices were poor with high fixation losses and high false negative error. The field again showed advanced field loss with VFA of 21%. In view of advanced glaucomatous damage, we have done a 10-2 field where the reliability indices were poor with high negative error, false negative error of 40%. The central points close to the fixation were normal. However, this cannot be considered and macular split could not be ruled out because of poor reliability. Diagnosis, both eye primary open angle glaucoma, right eye advanced glaucoma and left eye severe glaucoma approaching glaucomatous optic atrophy on maximum tolerable medical therapy, non-compliant to treatment. This is the summary of the patient's management. When the patient presented in the OPD for the first time in 2016, his IOP was 32 in the right eye and 28 in the left eye. He was started on eye drops, Combigan elsewhere. And when he came back to us for follow-up in 2016 to the OPD, his IOP was 28 in the right eye and 20 in the left eye. We have done a baseline field and we have added eye drops latanoprost for the patient. And on Combigan and latanoprost, his IOP was 16 mm of mercury in both the eyes. However, he was lost to follow-up in 2017. And he came back to us after 3 years in 2020. And he was not using any anti-glaucoma medication. He stopped all the medications by himself. And his IOP was 44 in the right eye and 42 in the left eye. We restarted the same group of medicine, that is Combigan and Saflutan, and called him back for follow-up, and his IOP was 24 and 20. We have repeated the fields and we suspected progression. Therefore, we advised trabeclectomy for the patient. However, the patient was not willing and he was very apprehensive for the surgery. Therefore, we added eye drops dorzolamide for the patient, and on follow-up, his IOP was 16 in the right eye and 14 in the left eye. Again, the patient was lost to follow-up, and he was not using anti-glaucoma medications regularly. He restarted all the medicines by himself just 1 month prior to the visit, and he came back to us in 2021 February, and his IOP was 14 mm of mercury in both the eyes. Therefore, we advised visual fields, repeat fields to look for progression, diurnal variation test to look for any IOP spikes during the day, because his IOP at presentation is 14, but we wanted to rule out IOP spikes throughout the day. And we also advised trabeclectomy with mitomycin for the patient. However, he did not follow up since then. These are the points for discussion. These are the few dilemmas we faced in the management of the patient. So when non-compliance was suspected, should glaucoma filtration surgery be the first line of management without restarting medication? That is, when the patient came to us in 2020 without any use of anti-glaucoma medication with IOP of 44 and 42, should we consider trabeclectomy at that point itself, and like after acutely controlling the IOP, instead of restarting him on the medicines? And what is the best way to monitor progression in patients who have non-reliable fields and can't afford an OCT? For example, our patient, he had financial constraints, so we had to decide upon one investigation. So we decided to go with the visual fields. But is it okay to go with a non-reliable field, but with repeatable pattern, which was coinciding with the progressing disc changes as a parameter to monitor progression and for documentation? And are lasers an option in such advanced glaucomas for patients who are not willing for surgery and who are non-compliant to topical medicines? Are free samples given in the OPD that are expensive a barrier to for adherence to medical therapy, because he might have a problem during refilling the medicines that are expensive? What are the intraoperative and postoperative modifications that need to be done in a non-compliant patient who undergo trabeclectomy? For example, intraoperatively, is there any suture-related modifications, like should we go with all fixed sutures? Because if we use a releasable suture, he might not come back for follow-up to remove the releasable suture, and leaving the releasable suture in place itself can act as a nidus for infection and can also cause a corneal delen at a later stages. Or should we go with all releasable sutures, because he might not turn up for argon laser suturolysis at a later date? Or like post-operatively also, should we avoid any maneuvers like home massage for these patients who have underfiltering bleb, rather consider early needling for these patients? Also, intraoperatively, should we is there any modification in terms of dosage and duration of mitomycin C, because mitomycin itself can cause a late bleb leak, and we might miss out on a late bleb leak if these patients do not come for follow-up. These are my dilemmas in the management for the patient.
Presentation, fantastic presentation, Pravina.
Thank you, sir.
Thank you very much for the very, very exhaustive presentation. And we open the discussion now.
It is not unusual to see such a presentation in our.
What is the age of the patient?
58.
58.
It's mostly, this the management aspect, so mainly it's not only the intraocular pressure, we have to look at the patient as a whole. The patient, socioeconomical aspect, literacy, and the distance from the hospital to the native place. All these things we have to take into consideration. Because in such case, 2016 he come, and after that 17, then no follow-up. And 20 only patient has come for the follow-up.
Yes, sir.
The ideal treatment I will advise is the surgery. And of course, the progression, your second question, I don't think OCT is not at all necessary, because a careful examination of the optic disc, and of course visual field is very, very important. Wherever possible, better to do a visual field. So That's a thing. I don't think we will have any role in such a patient where there is a poor compliant patient, with so much of high intraocular pressure. Laser is not SLT. I don't think it will lower the pressure 6 to 8 millimeter, not more than that. Of course, as Murali pointed out, micropulse may work. I don't know.
Probably micropulse would have been given options, sir, because he was apprehensive about surgery.
Yeah, yes. So, yes. Can give an option, yes.
I just want to ask one question to all the panelists. How do you know that the patient is compliant or not compliant with the drugs? Is there any way to find out?
It's very, very difficult.
I think Mohan, you need 1 hour to discuss that. Compliance by itself and adherence is a huge topic. A huge topic. I think that's where I think probably the maturity and seniority of a glaucoma specialist comes in.
I'll tell you when we have Madras Eye, we use the drops. Instead of using the drops 4 times, I use only 1 or 2 times. Even as doctors, ophthalmologists, we are not compliant.
No, you can assume that the average glaucoma patient or every glaucoma patient is non-compliant to a large extent. And suppose you tell them to use drops twice a day for a month, they'll probably apply once a day for a few days in a month. So that's quite common, and I think it's human nature, and you can't blame anybody for that. You can't actually confront a patient, you can't scold a patient, you can't be offensive or aggressive. So it's quite common. So what you can do, simple methods is look for the IOP and the disc and the field to look for progression. And despite, say, so-called target pressure being achieved, it's progressing, you have to sort of reset the target pressure and consider non-compliance. Also check the number of bottles the patient has been using.
Yeah, that's very important.
Suppose you can ask the patient casually, எத்தனை bottle வாங்கிருக்கீங்க? ஒரு 6 மாசத்துல ஒரு 3 bottle போட்டீங்க, 2 bottle போட்டீங்க. Immediately you'll know how compliant the patient has been. And you can also know
எந்த பாட்டிலும் கேட்பாரு.
கண்ணில் போடுற பாட்டில்.
அதுதான் நிறைய போட்டுப்பாங்க.
And that is one way. Second is to ask, is cost an issue? Ask some leading questions to the attender. Is cost an issue? Are you able to come for follow-up? Are you applying the drops correctly? Can you demonstrate how the drop is applied? And is going and coming a barrier for you? All kinds of leading questions you can ask. I think there is no one answer for all non-compliant patients. There's so many methods of finding it out. And the solution also has to be tailor-made to each situation. You can't actually offer the same thing to everybody. So non-compliance is a very big problem. And I think most centers have shown that 3/4 of patients don't come. I'm surprised that the patient has come back so many times to Ramchandra, despite defaulting so many times. They in fact go away to some other place, they don't turn up at all. So I think good counseling here is the key. You have to really counsel the patient, and once the patient has come back to you, keep counseling the patient, keep talking to the patient, discuss all the options available, laser or micropulse or medication or surgery. I think here we have no choice but to do a surgery, and proper counseling is what is very, very important here.
Here, the problem is whatever the medication give, the cost of medication, the patient will not have any appreciable benefit. மருந்து போட்டேன் ஒன்றும் சரியாகல, ஒன்றும் பார்வை இல்லை. That type of answer only you will get.
Yes, absolutely, sir.
So we have to talk to them. As already pointed out, a strong counseling is very, very important. Why they have to take medication regularly? What happens if they don't take medication? That type of counseling is, and also what will happen to the blindness and compared to cataract, they may think it's a cataract, similar to cataract. No? So we have to, all these things are very, very important when you treat. Not like treating a cataract or ACCO, because glaucoma management itself is very, very good. For that, you should have a good doctor-patient relationship. Very, very important, because patient has to come for follow-through to his life. So not like cataract, just you do phaco and you forget about the patient also will not come unless there is a PCO.
Absolutely, sir.
Yeah.
I think counseling is very important. You need to talk to the patient and tell them it's like a diabetes and hypertension. You need to do this lifelong. You have to take medication. That's what I tell them.
And also you have to tell little bit about the side effect of the medications. You given Lumigan or something else, next day patient will have hyperemia, they will never use the drop. Suppose in advance, we have a little bit irritation, then they will make up their mind. They will continue the drops. Instead, no, they will not, they will never accept all these problems. So we have to really talk to them about the disease and the outcome and the possible complications of the treatment, everything.
Okay, sir. I think we have had a good session, sir. Good discussion.
Thank you, sir.
Presentations. Ravi Shankar, over to the over to Ravi Shankar for a vote of thanks.
Thank you, Mohan.
Thank you once again, sir. And at the outset, I would like to thank the president of TNOA, Dr. Thangavelu, for giving us this opportunity, and the entire team of office bearers and the management committee, including Dr. Mohan, the president-elect, and Vice President Dr. Ramakrishnan, for giving us the opportunity. It was definitely enlightening for me personally, as for the delegates would definitely help me to accept that the presentations made today by the speakers, as well as the case presentations, were very interesting and very informative at the end of the day. Thank you so much. And I would like to thank the chairperson of the day, Dr. Ramakrishnan, sir. Thank you for accepting the chairperson and giving your views. And the panelists of the day, Dr. Chitra from RAOGOH, Dr. Ronnie George, Shankar Netralaya, Dr. Satyan Pathasarathi, and Dr. Murli Ariga for joining us, and as well as giving a topic of presentations today. And I sincerely thank the postgraduates, Ramachandra, Davina, Dr. Hemapriya from Arya, Dharini from Agarwal, of the institutions, for allowing you to present so much. And I need to thank again Mr. Ramesh and Mr. Shekhar for this meeting, and also the technical.
Thank the most beautiful ophthalmologist,
Numerotech Sai and Mrs. Manjula. Right.
Ravi Shankar.
Sir? Yeah, tell me, sir. Yeah, I'm able to hear you, sir.
Most beautiful ophthalmologist, Dr. Nagalakshmi.
Yes, sir. I'm about to say that Dr. Nagalakshmi from Dr. Kamakshi Memorial Hospital and MN Hospital. Thank you so much. And Alargan, Ramesh, and Shekhar, Sai, and Mrs. Manjula Sai from Numerotech, and everyone, including all the delegates who had participated on this online webinar platform. Thank you once again. And it is humble request from Tamil Nadu often to request you to be very cautious, kindly follow all the protocols of hospitals, clinics, and institutions. Looking forward to see you all once again in a short while. Thank you so much.
Hey, thank you very much. Stay home, stay safe, stay healthy. Bye. See you again in a few weeks for the next TNOA webinar. See you, sir. Thank you, well.
Thank you, sir.
Satyan, boss, thank you.